Good evening, students. There was a slight delay in the beginning of the class. Good evening, students. Good afternoon. There was a slight delay in the beginning of the class. Vikas, Arun, Aditya. So, as you know, the purpose of today's class is we are going to have 2 days session. I am trying to finish within 2 hours, but it may extend 2 hours. So, each day it will be 2-hour session today and tomorrow, starting 4 in the evening. And our focus is basically the upcoming exam, INI-CET, in the month of May this year. And we are trying to take care of some of the diagram-based questions. So, as I see, lot many names now, difficult to, but good evening, good afternoon to you all. Yes, that is correct. I won't be stopping in 2 hours because the content is 2 hours, and I understand it will definitely extend beyond that. So, be prepared for the session might be reaching 3 hours today. Okay, so we are starting with the very first description. You know, everything should start from embryology, and in embryology there is a process called as gastrulation. As you see in this diagram, we have taken a transverse section of the developing embryo after gastrulation, and after gastrulation we'll see there are some germ layers, ectoderm, mesoderm, endoderm. But before we start talking about this diagram, let us draw one ourselves. So, we are talking about the process which is called as gastrulation. Gastrulation is happening in week 3 of development, and it is the epiblast cells which will be giving us some germ layers. So, in the beginning we used to say epiblast will be giving us 3 germ layers, which are the ectoderm, mesoderm, and the endoderm. In here also we have to understand the first to appear is the endoderm, next comes the mesoderm, and then the lastly ectoderm. So, that is the sequence of developing. Epiblast will be giving us 3 germ layers, but recently there is a concept that there is a 4th germ layer also, and that 4th germ layer is neural crest cells. Now, there are some questions which keep coming on neural crest cells derivative. These are migratory cells, and they keep migrating to various regions of the body. So, we are going to talk about some problems with the migration. Sometimes they may not be migrating in the head neck region. There is a DiGeorge syndrome. There is another syndrome which is Hirschsprung disease, which we can talk about. So, one of that is the DiGeorge syndrome, another one is Hirschsprung disease. These are because of the problems of migration of neural crest cells. So, basically gastrulation is the process which will happen in the 3rd week of development, where the epiblast cells will be giving us 3 germ layers. Now, it has become 4th germ layer also. The very first to appear is endoderm, then comes the mesoderm. Lastly, we have the ectoderm, but still beyond that is neural crest cells, which are migratory cells. With this insight, let us now move on to this diagram which we were looking at. In this diagram you can see for yourself that there are 2 cavities. It is a transverse section of the embryo post gastrulation. So, there is one cavity which is dorsal, the amniotic cavity, one cavity which is ventral, the yolk sac cavity, and then there is the trilaminar disc. The supermost or dorsal most is the ectoderm, which you can see. In the middle we have the mesoderm, and then the ventral is the endoderm. Endoderm is lining the yolk sac cavity, and ectoderm is at the floor of amniotic cavity. Now, you see something which is notochord mentioned here. Notochord is considered as the axial mesoderm. It is a mesoderm which is in the axis, and it is important because notochord is going to stimulate the overlying ectoderm and forms the neural plate. Now as the ectoderm, which is stimulated to form neural plate, later it will become neural tube, and the neural tube will form central nervous system, that is brain and the spinal cord. I'll repeat once again. In the mesoderm, in the central region, there is axial mesoderm, which is also called notochord. Notochord is important because it is going to stimulate the overlying ectoderm, and this ectoderm, which is overlying the notochord, becomes neural plate ectoderm. The neural plate will become neural tube, and neural tube will become central nervous system, that is brain and spinal cord. Now if CNS is coming from the neural plate, then where is PNS coming from? Peripheral nervous system. For peripheral nervous system, we find that there is the cells which we were talking about, as we can mention them here, the neural crest cells. And these neural crest cells, as we have mentioned earlier, it used to be a concept that neural crest cells will come from neural ectoderm. But now the concept is that neural crest cells actually come from the epiblast cells only, fourth germ layer. And it is the neural crest cells which will be contributing to the peripheral nervous system. When you say peripheral nervous system, you can talk about the ganglia, most of the ganglia in our body. Maybe it is sympathetic ganglia, parasympathetic ganglia, or the dorsal root ganglia, mesenteric ganglia, Auerbach's plexus, Meissner plexus. Most of the ganglia, they are in the peripheral nervous system, would come from neural crest cells, which itself would come from epiblast. So this is the description which we are going to proceed further with. We want to talk about neural crest cell derivatives and their problems, sometime like if there is a problem with the migration. With this insight, as we move further, you notice this diagram, because examiners these days, they give you some of the diagrams like you see here. One, a diagram came which was, let me shift the diagram a little bit to this side so that it is not hidden behind me. So the diagram which the examiner gave you was a neural tube. This is the notochord, and one arrow mark was given dorsolateral to the neural tube, and not only there but also some cells here. So basically they were talking about the neural crest cells. They gave this diagram of neural tube and the notochord and then neural crest cells. They wanted you to enumerate the derivatives of neural crest cells. So as we have told, the neural crest cells, basically they are migratory cells, and as they are migrating, they will be contributing to most of the ganglia in our body, like you can see in this diagram now. The cells are migrating. In here, in this diagram, you can find this is the neural tube, and neural tube is basically going to form brain and spinal cord. Let us say this section has been taken where you have the spinal cord. So this is the spinal cord. So the spinal cord, related with spinal cord, you will have some ganglia like dorsal root ganglia. Dorsal root ganglion, which is a sensory ganglion related with spinal cord, would have come from neural crest cell. Then along with the spinal cord, you have sympathetic chain. There will be some sympathetic ganglia. So those sympathetic ganglia in the sympathetic chain, they are also from neural crest cell. Neural crest cell will not only form the sympathetic ganglia, they will also form parasympathetic ganglia like nerve number 5, 7, 9, 10. They have some ganglia, you know, trigeminal ganglion, the glossopharyngeal or the vagus ganglion. They are all coming from neural crest cell. Neural crest cells are also forming pre-aortic ganglion. Pre-aortic, like in the abdomen, you have the gut tube, aorta giving you the branches to foregut, midgut, hindgut. For example, celiac artery for foregut, superior mesenteric artery for midgut, inferior mesenteric artery for hindgut. And each gut tube will have its own respective ganglia. So in front of the aorta, that is pre-aorta, in front of aorta, you'll have some blood vessels like celiac artery, so a related ganglion, celiac ganglion. Superior mesenteric artery for midgut, superior mesenteric ganglion. Inferior mesenteric artery for hindgut, inferior mesenteric ganglion. These are pre-aortic ganglia, and even they are coming from neural crest cell. Neural crest cell will also form the enteric ganglia like Auerbach's ganglia or Meissner ganglia. They are in the wall of the gut tube. So in the gut tube you have submucosal plexus and myenteric plexus. Myenteric is Auerbach's plexus and submucosal is Meissner plexus. You know, sometimes there is a problem of migration of neural crest cells and they do not reach the distal colon. If they do not reach the distal colon, there will be absence of the ganglia. Basically, these are parasympathetic ganglia. And if the Auerbach's ganglia or Meissner ganglia, they are missing from the colon, you say, and it is since birth. So, congenital, aganglionic, megacolon. Now, why the colon becomes mega? Defect of neural crest cell migration, they could not reach here. So there was no Auerbach's ganglia or Meissner ganglia. They are parasympathetic ganglia. What is the function of parasympathetic system? Evacuation. They increase the peristalsis for evacuation. But if you do not have the peristalsis, then there will be retention of fecal retention. Now if there is fecal retention, what the colon will become? Large, mega colon. So if you have problem with the migration of neural crest cell to the distal part of the intestine, that is the colon, you will have congenital aganglionic megacolon. This is one thing. Now what about the DiGeorge syndrome? These neural crest cells, they not only have this function of forming peripheral nervous system or ganglia, it is also contributing to some other structures. Like in our body there is mesoderm, but mesoderm is two types, primary and secondary. The epiblast, which was giving us the 3-germ layer, the mesoderm, that is primary. But there is a secondary mesenchyme also. Let us show that now. So as we talk about that mesoderm, we are drawing this diagram. You see, this is the transverse section of the embryo, the 3-germ layers, and we are telling this is the notochord. That is the axial mesoderm. It was important for us because it was stimulating overlying ectoderm, so that you can have what is called as neural plate, will form neural tube and will form central nervous system, that is brain and spinal cord. This much we have seen. So this is axial mesoderm, the notochord, stimulating the overlying ectoderm, forming neural plate, and neural plate will form neural tube, will form central nervous system, the brain and the spinal cord. Now what about the peripheral nervous system? We told epiblast will give us some more cells which are here. They are called as the neural crest cells, and it is neural crest cells which will contribute to peripheral nervous system and most of the ganglia. Neural crest cells have other functions also. So what is the other function of neural crest cell? You will notice neural crest cell can form mesenchyme. Mesenchyme is the early term for mesoderm. So it is forming mesoderm. But then which mesoderm? This is called as secondary mesenchyme or secondary mesoderm, because you have to understand the primary mesoderm is already there. So this is the primary mesoderm here, what you are looking at. This is primary mesoderm. Notochord belong to primary mesoderm. So who gave the primary mesoderm? The epiblast. Epiblast gives us the primary mesoderm. Then who gave us the secondary mesoderm? That is neural crest cells, derived secondary mesenchyme. So epiblast will give us the neural crest cell, and neural crest cell will give secondary mesenchyme. What is the importance of this secondary mesenchyme? See, most of the body will have primary mesoderm except certain places like anterolateral aspect of the head and neck region. In the anterior and lateral aspect of the head and neck region, it is mostly secondary mesenchyme. Now once you say that, and we mention here that secondary mesenchyme is forming most of the head and neck mesenchyme, what it will be contributing towards? Like most of the skull bones, especially facial skeleton, anterior and lateral, the mandible bone, the hyoid bone, pharyngeal arch bones, they all come from neural crest cell. The mesoderm in this region is mostly secondary mesoderm. Okay, skull bones, what else it will form? It will form most of the eyeball. Most of the eyeball mesoderm. So eyeball has many contributions, some of that is mesoderm, but most of the mesoderm in eyeball is not primary mesoderm. then what it is? It is secondary mesoderm, which is derived from neural crest cell. And what else it gives? It will give us the pharyngeal arches. For example, bones we have discussed. You can talk about bones like mandible bone or hyoid bone. What else it will give? It will give us the developing heart, aorta, pulmonary septum. So one other structure which it gives is AP septum, which is also called as conotruncal septum. In DiGeorge syndrome, there is a problem of neural crest cell migrating in this region. That is why there can be skull defect, small mandible, there can be AP septum anomalies. AP septum anomalies like what? Tetralogy of Fallot, persistent truncus arteriosus, or it could be transposition of great vessels. So if we are talking about this DiGeorge syndrome, it is a problem of neural crest cell, and there can be AP septum anomalies like tetralogy of Fallot or transposition of great vessels or persistent truncus arteriosus. It is the cardiovascular defects which are going to kill most of the cases in DiGeorge syndrome. What is the most common cause of death in DiGeorge syndrome? Most common cause of death in DiGeorge syndrome are cardiovascular defects like these, AP septum anomalies. There is a problem with this AP septum. Now the entire discussion depends upon one factor. The neural crest cell is a question which used to come 20 years back, 10 years back, 5 years back, even presently it is coming and will keep coming because it is one topic which is huge and difficult to manage. Now as we just want to revise whatever we have discussed, you can see here the details now. Let me take some other color. I have discussed that it is ganglia like parasympathetic ganglia, the number 5, 7, 9, 10. Not only parasympathetic ganglia, but also sympathetic ganglia like you see here running in the sympathetic chain. Or it could be related with spinal cord dorsal root ganglia, is also from neural crest cell. It is forming pre-aortic ganglia, it is forming enteric ganglia. Pre-aortic we have discussed, superior mesenteric ganglion for foregut, superior mesenteric for midgut, celiac for the foregut, inferior mesenteric ganglion for the hindgut. Those ganglia plus Auerbach's and Meissner plexus plus neural crest cells also contribute to adrenal medulla sympathetic neurons. There are some sympathetic neurons secreting adrenaline, suprarenal gland. This is kidney, this is the suprarenal gland. Adrenal medulla, the sympathetic cells, neurons are from neural crest cells. Then I told neural crest cell will contribute to head and neck mesenchyme, secondary mesenchyme, which you can see for yourself. These are the diagrams. In these diagrams, you can say what are the derivatives again. See, most of the eyeball mesoderm is from neural crest cell. Most of the skull bones, especially anterior lateral, like facial skeleton, is from neural crest cell. Neural crest cell give you AP septum, the conotruncal septum, other name of AP septum, and if there is a problem with the neural crest cell, DiGeorge syndrome, there can be AP septum anomalies like we have discussed, transposition, great vessels, persistent truncus arteriosus, or there can be other problems, and most common cause of death in DiGeorge syndrome is cardiovascular defect. And pharyngeal arches, bones like malleus, incus, stapes, hyoid bone. Malleus, incus developing in first arch, stapes developing in second arch, the hyoid, upper hyoid in the second arch, lower hyoid in third arch. These bones, they'll be having problems if there is a problem of neural crest cell migration. Neural crest cell form most of the head and neck mesoderm like skin dermis. In the below the epithelium you have, this is epidermis epithelium and below that is the dermis. So skin dermis in this region, or most of the mesenchyme here in this region is from neural crest cell. Neural crest cell also form odontoblast and the teeth. The teeth will have dentine. Dentine come from odontoblast. Odontoblast will come from neural crest cell. So these are the derivatives of neural crest cell. This is what I wanted you to understand. And in the skin, though the skin epithelium is from surface ectoderm, in the skin epithelium there are cells called as the melanoblast, and those melanoblasts which will normally get detached from the surrounding, but I should be looking at the chat as well. Now, see, you should understand which exam you are preparing for. You are preparing for INI-CET exam. INI-CET exam is conducted by professors at AIIMS, JIPMER. If you name some of the teachers who are teaching you, you should understand. Let me not go into that direction. Okay, so histology. Now, as we look at this diagram, I'll ask you in the chat, you have to mention what is this histology specimen belonging to, and this one, this one, this one. Let us say this is A, this is B, this is C, and that is D. And I'll give you the options. Which of these is a lymphoid tissue, for example lymph node? Which of these belong to the kidney, showing renal glomeruli? Which of these is a gland, like pancreas gland with islet of Langerhans? And which of these is testis, showing seminiferous tubules? So, and in the exam, you should understand, you don't have much time. You have mostly 20 to 40 seconds to identify the slide, because then after that you have to read the question and read the options also. So as you're telling, A is kidney, okay, right. A is kidney, I agree with that. And then B is pancreas, agree, yes. What is C? C is lymphoid tissue, correct. I know you people are well trained and you have practiced a lot, so you won't be making mistakes, at least in this class. In the exam we do make mistakes which are actually blunders. We should not make blunders, means despite knowing the answer we are making it, marking it wrong. So our purpose is to reduce those blunders. And D is testis, fantastic. So you already have answered. Now we are going into details. As we go into the details, because obviously once the examiner has asked you, you have to understand, if a slide has come and most of the students have already answered it perfectly, then next time examiner is not going to repeat the same information, he'll go a bit deeper. That is how these exams are. In the beginning they'll ask you simple things. If people answer, then a little bit deeper and more deeper. So like they were asking, which was actually an information for me as well, because this question belongs to NRP plus physiology. They were asking about the juxtaglomerular apparatus. What exactly is the location of juxtaglomerular apparatus? At the junction of PCT, DCT, or loop of Henle DCT, or DCT collecting tubule, like that. So we'll be talking about JGA. Take this from me that juxtaglomerular apparatus is going to be a question. Most of the time it used to come, it is coming, and it'll keep coming, because these are some of the topics which are always, they are evergreen topics. Now before I start working upon this diagram, let me just tell you some details which are relevant, then we can move on further. Kidney will have two parts embryologically. There will be one portion which is, you can say, excretory, the one which will form urine, and then once the urine is formed there will be collecting system. So in the excretory system which will form urine, you will have the nephron, and then there will be collecting system which will have some ureter like it comes from ureteric bud. Because it is coming from ureteric bud, so it will form ureter to collect the urine. But our focus is on nephron at the moment. Now, because we are talking about histology here, if you are looking at a nephron, it will be something like this. Nephron will have a Bowman's capsule, then there will be a proximal convoluted tubule. After that, there will be a loop of Henle, and then there will be a distal convoluted tubule. So as you see in this diagram, we are having Bowman's capsule here, then we are having the PCT. After that, we will have this loop of Henle, and then we'll have distal convoluted tubule. Now, what is the purpose of kidney? To form urine. And how do you form urine? You will see that there are some afferent arteriole. Afferent means which is bringing the blood. So afferent arteriole, and then there is one efferent. Efferent means exit, outgoing. So afferent A for arrival. A for A, arrival is afferent. E for E, efferent is for exit. So some blood comes and some blood goes. These afferent arterioles, they will be forming some capillary plexus which is called as glomerulus. So this is glomerulus, and in glomerulus you will have some cells which are connective tissue, which are mesenchymal cells, mesangial cells. So along with this glomerulus, you will have some mesangial cells also, connective tissue cells. Now a question comes, glomerulus will have this blood, there will be ultrafiltrate of blood which is urine. That urine will be collected by Bowman's capsule, and most of the contents of urine like sodium should be absorbed back. The glucose should be absorbed back. Amino acid should be absorbed back, and that absorption can happen in PCT, in loop of Henle, in DCT. So reabsorption of the contents which were filtered in urine, it should happen. What is the lining epithelium of Bowman's capsule? What is the lining epithelium of PCT, DCT or loop of Henle? These are questions. Now you should know, if we are talking about the Bowman's capsule or loop of Henle, they have simple squamous epithelium. So as we talk about the Bowman's capsule or the loop of Henle, they'll have simple squamous epithelium, whereas PCT, DCT, they'll have simple cuboidal epithelium. Simple cuboidal epithelium. Now when you say this is a simple cuboidal epithelium, maybe PCT or DCT, how do you identify cuboidal epithelium? There will be a central spherical nucleus, and height of the cell is equal to breadth of the cell. So this is how we identify the DCT or PCT, the proximal convoluted tubule, distal convoluted tubule, because they'll be having simple cuboidal epithelium, and the cells are such that they have central spherical nucleus and height of the cell is equal to breadth of the cell. But there will be a difference. In PCT, there will be brush border. Now when you say PCT will have brush border, what is brush border? Brush border is, it will have microvilli, and these microvilli increase the surface area of absorption so that you can absorb more of sodium, glucose, amino acid. Now this brush border is present in PCT, not in DCT. DCT does have microvilli, but they are not forming brush border. So if a question comes, what is PCT lined by? You should say simple cuboidal epithelium with brush border. And what is DCT lined by? It is simple cuboidal epithelium with microvilli, but no brush border. And if you want to differentiate between them in histology, what you can do is, you can look at their lumen. So if the lumen is not clear, it is lot of microvilli, then it will be PCT. On the other hand, if you look at the DCT, the lumen will be clear and large also. So a large clear lumen belong to DCT because less of microvilli, no brush border. And in PCT, small lumen and clouded in sections, in histology sections, because it is a lot of microvilli with that picture. Now, as you are talking about loop of Henle, what is it lined by? Simple squamous epithelium. But then you should understand there is a part which is here, the descending limb, and there is a part which is here, the ascending limb. So epithelium of the descending limb, ascending limb is low cuboidal epithelium, low cuboidal. Though loop of Henle, if a question comes, you should answer as simple squamous. But descending limb or ascending limb of loop of Henle is low cuboidal epithelium. And it is the junction of thick ascending limb, thick ascending limb. It is called thick because, thin means simple squamous and thick means cuboidal. So thick ascending limb, when it meets the DCT, that is the point where it will come close to the afferent arteriole, and that is where we will have the juxtaglomerular apparatus. So a question was, where is juxtaglomerular apparatus present? Of course, juxtaglomerular means close to glomerulus. And which part of glomerulus? Afferent arteriole. So you mean to say that this part of the nephron, which is a junction of thick ascending limb meeting with distal convoluted tubule, that point will come close to the glomerulus. Juxtaglomerular apparatus, yes, that is the point where you will have this function of the JGA. What is the function of JGA? See, juxtaglomerular apparatus, when we are talking about this JGA, it is detecting the blood pressure or the sodium concentration. If the BP goes down, if the sodium goes down, there is a detection mechanism like the distal convoluted tubule. The cells, they get modified and they form what is called as macula densa. So in DCT, you will find there are some macula densa cells, and macula densa cells, they detect the sodium concentration. If the sodium concentration was low, then they can secrete some components like adenosine, and that can cause vasoconstriction. Vasoconstriction where? In the afferent arteriole. So that means there can be vasoconstriction, there can be vasodilation. If you want vasodilation, you can release nitric oxide, more of physiology. But the point is, juxtaglomerular apparatus can detect the change of blood pressure or the change of sodium. Either it is decreasing or increasing. If it is less of blood pressure, what would you want? You want vasoconstriction to increase the blood pressure, basically. And that can be done by the macula densa of DCT. Or you will have the afferent arteriole, tunica media. So the tunica media in the afferent arteriole are forming JG cells. They contain some hormone called renin. So in the JGA, the afferent arteriole, tunica media, because it is arteriole, it will have tunica media. Tunica media cells, they form JG cells and they can secrete renin. Renin, angiotensin, aldosterone system. So renin, angiotensin, aldosterone system. If you have less of BP, if you have less of sodium detected by the macula densa of DCT, it can direct the JG cells. And JG cells will then release renin. Then there will be more of aldosterone. And if there is more of aldosterone, and there can be also vasoconstriction. So vasoconstriction means blood pressure will increase in the glomerular filtration rate, basically. You want to increase the GFR, basically. So that renin can release aldosterone. Aldosterone will then increase sodium absorption. So you had less of sodium, now you can have more of sodium absorption. So this is all physiology. But eventually, what we want to know is, if this is the diagram you are getting, what are the components? See, first of all, in this diagram, you can see this is the glomerulus. First of all, that is glomerulus. This area, bunch of capillaries, this is glomerulus, this is glomerulus. And what are these they are PCT and DCT, proximal convoluted tubule, distal convoluted tubule surrounding the glomerulus. And then you can have a magnified picture of juxtaglomerular apparatus here. Now as we zoom on this diagram, as you will notice, here you can see we are looking at one of the PCT, proximal convoluted tubule, and one DCT. Now how do you know that this is DCT? Distal convoluted tubule, because it is clear lumen. And how do you know it is PCT? Because the lumen is not clear. Lot of microvilli, so less evident lumen, and here less of microvilli, so more evident lumen. Now in the DCT, there are cuboidal cells modified as columnar cells, becoming what is called as macula densa. So let me zoom this a little bit more, and you can see what we are talking about is this here. These cells, they are becoming columnar. The cuboidal cells of DCT, D for distal convoluted tubule, P for proximal convoluted tubule, less conspicuous lumen in PCT, more conspicuous lumen in DCT. In the wall of DCT you have macula densa cells. They are detecting the sodium concentration. If there is less of sodium, they can release adenosine, causing vasoconstriction, and also release of renin from afferent arteriole. So where is afferent arteriole then? You will see AA, the afferent arteriole, and it is the afferent arteriole which is actually bringing in the blood into the glomerulus. This is the glomerulus where you have capillaries and mesangial cells. So afferent arteriole brings the blood, and it is the efferent arteriole which will take the blood out. Exit is efferent, arrival is afferent. So blood comes here, ultrafiltrate of blood, and then efferent arteriole blood goes back. It is the afferent arteriole which has tunica media, and tunica media will have the JG cells. So these are the JG cells here, and these JG cells, they will have renin. The renin angiotensin aldosterone system, which can work for vasoconstriction or dilation, either way around. It is a feedback mechanism. What is this L? L is the Lacey cells, and as you talk about these Lacey cells, they are basically extraglomerular mesangial cells, and they also can secrete renin. So renin can be secreted by Lacey cell, which is extraglomerular mesangial cells, connective tissue cells. Renin can be secreted by the JG cells of afferent arteriole in response to the macula densa telling them there is less of sodium absorption happening in DCT. So this is juxtaglomerular apparatus. Now once we are through this, we can move on to, and see, this is the slide which we were talking about. This is the glomerular capillaries, the afferent arteriole, and it is the junction where the thick ascending limb of loop of Henle comes near the afferent arteriole and becomes the DCT. So as you can notice, this is the DCT, and this is the afferent arteriole, and this is the thick ascending limb of loop of Henle. So thick ascending limb of loop of Henle, as we see, this is low cuboidal cells, and as it is reaching the afferent arteriole here, and it is changing into what is called as the distal convoluted tubule. The JGA belongs to DCT basically, but at the junction of thick ascending limb of loop of Henle with DCT in proximity with afferent arteriole. Now you might be wondering why I am being so specific about these things, because take it from me, next time a simple question will not come. They'll go into more depth. And it can be anatomy question, it can be physiology question also. So I have given you anatomy plus physiology of both of them. Now how do you identify the kidney? Is by the fact that you have these glomerular capillaries and around that you can see there is a space. This is where we call it as urinary space, and that urinary space is where the urine is filtered, because ultrafiltrate of blood, urine will be filtered here. So that is how you identify the glomerulus. And PCT, DCT, you can see yourself. If it is something like this, this is a DCT, and if you see something which is close, because PCT will be close, say obscured lumen basically, then it will be PCT. So PCT, DCT can be identified surrounding these glomeruli. This is kidney. Now as we are moving further, you want to talk about the pancreas. Again, these slides are coming. So how have you identified the pancreas? Is by the fact that it will have islet of Langerhans, having alpha cell, beta cell, delta cell. Alpha cell giving you glucagon, the beta cell giving you insulin, delta cell giving you some other hormones, paracrine hormones you can say. Now the thing is that this appears like kidney only. This could be giving a false impression of glomerulus, and this could be giving the false impression of PCT, DCT. But then this is not PCT, DCT, because none of them will have a very conspicuous lumen as DCT would be having. These are pancreatic acini basically, and though they will have lumen, but the lumen is not that evident. If you see the evident lumen, then it is a duct which you see, the duct which will carry exocrine secretion from the pancreatic acini, which is bicarbonate rich digestive juices. But it is endocrine plus exocrine organ, the pancreas, and it is islet of Langerhans. As you have noticed, if you confuse it with kidney, it will not have a space which we saw in the kidney. There is no space around this structure which was there in glomerulus kidney. So missing space, that gives you the idea that this is not kidney, this is pancreas. Now if we are looking at the other slide, sometimes there can be confusion between pancreas and salivary gland. So pancreas and salivary gland, what is the difference? Say for example, this is submandibular salivary gland. Submandibular salivary gland is mixed salivary gland. It is serous plus mucus. So if you are talking about the pancreas, it is only serous acini. They are all serous acini. Serous acini are identified by the fact they are staining dark pink in color. But if you look into submandibular salivary gland, you will not only have the serous acini, but there are mucus acini also. And if we are talking about the mucus acini, how will you identify them? You see, these are all mucus acini, and they are identified by the fact that they will have mucus, empty looking cells. So empty looking cells as compared with the serous acini. This is a duct here, and in salivary gland the duct are specifically, one typical duct type is seen, and we call it as striated duct. Striated ducts are seen in salivary glands. They are for ion transport involved in saliva secretion. So striated duct is a typical feature of the salivary gland involved in some ion transport and important for saliva formation. You don't have striated ducts in the pancreas. In pancreas, the ducts are not striated. Striated ducts are typical feature only seen in salivary glands versus the pancreas. So this is pancreas with islet of Langerhans, serous acini, which you might confuse with the salivary gland. But in salivary gland, you can have striated ducts. Plus salivary glands can have the serous acini, mucus acini, plus one typical finding which you will notice here. These are the serous acini sitting on the mucinous acini, which are called as serous demilunes. So if you are finding a serous demilune, like a cap on the head of mucus acinus. So on mucus acinus you have a serous acinus. That kind of finding can only be seen in submandibular or sublingual salivary gland. You cannot see that in pancreas. Why not in pancreas? Because in pancreas we can have only serous acini. There are no mucus acini. So if you do not have mucus acini, you cannot have serous demilune. So serous demilune is a feature only for salivary gland, not for pancreas. Now, how do we decide what to teach you and what not to teach you? It is decided by the fact that in the last 20 years, starting from year 2002 to year 2022, which questions have come to you in exams like All India PG and AIMS exam, because you are preparing for INI-CET exam. INI-CET exam examiners are the people who are at AIMS, the professors who have experience of 50 years almost in teaching. They prepare questions for you, and these are the same examiner who have been preparing such questions since 20 years, and I have been watching them. So when you go through the previous year questions, you get an idea that what they are interested in asking for and what they'll be asking in the next coming exam. It is a lot of hard work to identify which information to give and which information to hold. If you just talk about a class on salivary gland, it can be 40 minutes class. But if I want to deliver something in 4 minutes, then I have to decide which information to delete and which to convey. And that is all coming from a lot of hard work going through that 20-year questions and deciding what to give you and what to hold back. Now, some of the students I have seen, they are writing some names. This teacher is good, that teacher is, every teacher is good, but each teacher has their own capabilities. If you were exposed to the exam and if you have actually been unsuccessful, failure teaches you more than success. Once you give the exam and you could not score a rank, then you will realize that what I am talking about. If you have been through the previous year questions, then you will realize what I am talking about. Otherwise, just simply sitting and telling anything and everything doesn't make sense. It is your life. You should be serious about your life. You cannot be casual. Now, how do you know that this is a lymph node? We know it is a lymphoid tissue, first of all, because we find that it is having a lot of blue dots. Lot of blue dots. Now, what are these blue dots? They are the lymphocytes, and lymphocytes appear like blue dots because the cell is such that most of it is occupied by the nucleus. It's a very large nucleus, and there'll be very little of cytoplasm around. So very thin peripheral rim of cytoplasm, most of it is nucleus. So nucleus is basophilic, take more of blue stain, hematoxylin, blue dots. Now, this is a lymphoid tissue identified by the fact it is having a lot of blue dots. If you magnify, you will find the lymph node is having 3 regions. In the periphery, you will find a cortex, then there is a paracortex, and then if you go still deeper, you will have the medulla. So there will be a capsule, subcapsular sinus, which will be filled with lymph because lymph node receives lymph. So as the lymph will come, it will be in the subcapsular, this is the capsule here, and this is subcapsular sinus, which will be filled with. And it is typical of a lymph node that it has a very large subcapsular sinus. You do not find this big subcapsular sinus in spleen. Spleen doesn't have that. Spleen is also a lymphoid tissue, but doesn't have such a large subcapsular sinus. And spleen will not have the cortex or paracortex or medulla. Spleen will have red pulp and white pulp. So differentiation between a lymph node and spleen. Now, what is there in cortex? You will find there are some lymphoid follicles, lymphoid nodules, And these lymphoid nodules, they are mostly B lymphocytes. And if you are talking about the B lymphocytes are going to change into plasma cell, and then plasma cell will give you antibodies, humoral immunity. So in the lymph node, in the cortex, you will have lymphoid follicles, and lymphoid follicles will have B lymphocyte turning into plasma cell, giving antibodies, humoral immunity. But if you go deeper, you will not have lymphoid follicles. You will have the paracortex, and in the paracortex, what you find is that we are having T lymphocytes, cell-mediated immunity. Cell-mediated immunity by the T lymphocytes. And if you still go deeper in the medulla, there will be lot of lymph here, medullary sinuses. Like here, you can see medullary sinuses filled with lot of lymph. So where is cortex? Cortex, you see where you have these, lymphoid follicles. This is cortex. And where is paracortex? This is paracortex, where you have T lymphocyte. There you are having B lymphocyte. So in the cortex lymphoid nodules, you will have B lymphocyte. In the paracortex, you will have T lymphocyte. What is there in the lymph node medulla? You will have lymphoid sinuses filled with a lot of lymph. And what is lymph? Lymph is ultrafiltrate of blood, basically. So ultrafiltrate of blood, the lymph. And along with that, you can have macrophages or plasma cells also. So macrophages or plasma cells forming the medullary cords. Here you can have what are called as medullary cords, and in the medullary cords you will have macrophages or the plasma cells. Basically, immunity purpose, they are giving you antibodies, because plasma cell is what? It is a modified B lymphocyte only. So this is how you identify the lymph node. Now, as we proceed further, this is testis. And in the testis, this is the slide. How do you identify the testis slide? You will notice that we are having a lot of seminiferous tubules. These are the seminiferous tubules. And there are some interstitial cells of Leydig. So here, let me change the color. These are the interstitial cells of Leydig. Means between these seminiferous tubules. These are seminiferous tubules here. This is one seminiferous tubule, the other seminiferous tubule. And interspersed among them is Leydig cells. So Leydig cells, they give you hormones like testosterone. Leydig cells, interstitial cells of Leydig, they'll be giving you testosterone. But how do you find seminiferous tubule in kidney? How do you identify? These are all, you see these cells, they are the sperms projecting into the lumen, spermatocytes. So the question comes, which cell is at the basal region and which cell is towards the lumen? Towards the lumen you have sperms, spermatocytes, and towards the base you will have the gametogonia. So let us magnify this diagram, and as you are magnifying this diagram, you can see there is a magnified picture above here, and this is a schematic diagram. A question has come which is asking, enumerate the cell from base to the lumen side, basal to luminal side. So if this is the boundary of the seminiferous tubule, let us demarcate the boundary of seminiferous tubule. Around the seminiferous tubule you will have some myoid cells. They are contractile cells. They squeeze the seminiferous tubule and push the sperms further in the seminiferous tubule. So the very first cell, which is towards the periphery, should be a flat cell with flat nucleus. Flat cell with flat nucleus, myoid cell, which is a contractile cell, and that can be seen here, here, here. These are the nuclei which belong to myoid cell. Now, as you go deeper, you'll find spermatogonium changing into the primary spermatocyte, secondary spermatocyte, then spermatid, then spermatozoa. Spermatozoa will be towards the lumen. So sequence of cells you have to remember. The peripheral cell is myoid cell, then you have spermatogonia, primary spermatocyte. Why are you not seeing the secondary spermatocyte? We are not seeing the secondary spermatocyte because the life cycle of secondary spermatocyte is very short, and most of the sections which you take in testis will not show you secondary spermatocyte. They will be actually short-lived, so rarely seen. Immediately you see what is called spermatid and spermatozoa. Spermatozoa are identified by the fact that they will be towards the lumen and they'll have a tail, the flagella, and very small nucleus, condensed nucleus, because you are now getting ready to transport, so you have squeezed all the DNA, very small nucleus. So if you look at the spermatocytes, the nuclei are very small compared with the cell which was towards the periphery. In here, the largest cell will be primary spermatocyte. The largest nucleus belong to primary spermatocyte if you are talking about the gametocytes. In gametocytes, you are basically talking about spermatogonia, primary spermatocyte, secondary spermatocyte, or spermatid or the spermatocyte itself. The largest nucleus, largest cell is primary spermatocyte, and smallest nucleus belong to the spermatid. Now again, it depends which type of questions come to you, but see, my purpose was a simple purpose, and that began here. You should be able to identify the kidney slide, you should be identify the pancreas slide, you should be able to identify a lymphoid tissue like lymph node, or you should be able to identify the seminiferous tubules. Now, as we move further, you will see recently one question came, and it was giving you the matching, like in stomach which cell do you see, in liver which cell, in the testis which cell, and the options were parietal cell or Kupffer cell or dust cell in the lung. So accordingly we are preparing. See, here we are talking about the, say, stomach, and in the stomach we are having the gastric glands. In the gastric glands, upper half of gastric gland will have the pink cell, parietal, PP, pink for parietal, and towards the base of gastric gland you will have blue cell, so BB. Now what is this BB? Blue cell is towards the base and it is the chief cell. So these cells which are in the upper half of gastric gland, they are pink cell, parietal cell. Pink because they take a lot of eosin, pink stain, and towards the base you have the blue cells. Blue because they take more of basic stain or the hematoxylin, so they appear blue. They are called chief cell. Now talking about the parietal cell. Parietal cell is also called as oxyntic cell, and it is giving us the hydrochloric acid and intrinsic factor. You know, in pernicious anemia, when there is autoantibodies destroying the parietal cell, the pink cell, in pernicious anemia, when there are autoantibodies destroying the pink cell, the parietal cell, you will have less of hydrochloric acid and less of intrinsic factor. And if there is less of intrinsic factor, there will be a problem with the absorption of vitamin B12. And if there is a problem with the absorption of vitamin B12, then you see that there will be megaloblastic anemia, macrocytic anemia, and that macrocytic anemia is pernicious anemia. So it is due to deficiency of the pink cell or parietal cell. A question came, in absorption of vitamin B12, which part of intestine is not very important? And the choices were, is it the duodenum? First of all, this started with stomach only. Stomach, duodenum, or the jejunum, or the ileum. Question was, in pernicious anemia, macrocytic anemia, there is deficiency of vitamin B12. So in vitamin B12 absorption, which part of the following is least important in absorption? Which of the Tell me the answer, because it is a live session. Tell me the answer. The question is vitamin B12 absorption, which is the least important? Stomach, duodenum, jejunum or ileum? Jejunum, yes, jejunum is least important, because obviously stomach is important, it is giving us the intrinsic factor. Then what happens in duodenum? Duodenum, you demasking of intrinsic factor. And what happens in terminal ileum? Terminal ileum, you actually absorb the vitamin B12. Though in jejunum also there will be some vitamin B12 absorption, but among the options, if you have stomach, the duodenum, jejunum and ileum, least important is jejunum. Correct. Correct. Now, what about this chief cell? Chief cell has 3 names. And what are the 3 names of the chief cell? Chief cell is called as peptic cell, and it is also called as zymogen cell, because it is having zymogen granules. In the zymogen granules you are having pepsin enzyme. So as you see, this blue cell, basophilic cell towards the base, the blue cell, basophilic cell BB towards the base, is basophilic because takes more of hematoxylin here and appears blue, is called as chief cell, is also called as peptic cell, is also called zymogen cell. It has zymogen granules, which are basically the pepsin enzyme, which is inactive enzyme. So some of the details which we needed here. Now, what is the other name the examiner was asking? He was asking you about Kupffer cell. Now, Kupffer cell in the liver is a tissue resident macrophage. It is basically a lineage which is monocyte phagocytic series. So a monocyte phagocyte series, it's basically a monocyte which has come to liver and become a tissue resident macrophage, and it is Kupffer cell. Now Kupffer cell, how do you identify? Kupffer cell first of all will have very large nucleus, and it will have lot of engulfing, because it is a macrophage, phagocytosis. It will keep on eating some of the antigens basically, or it could be eating even the breakdown products of RBCs. So big cell, lot of inclusions which can be stained, and it will be found in the liver sinusoid. This is one of the liver sinusoid, and in the liver sinusoid you will find the endothelial cells are fenestrated. They are fenestrated, blood can leak out. It is not blood, basically plasma can leak out into a space which is called as the space of Desaix. So what is there in space of Desaix? It is perisinusoidal space. It is perisinusoidal space which is having ultrafiltrate of blood, because blood cannot escape as such, plasma will escape. It is, you can say, lymph kind of a structure, bile also you can say, bile, lymph, plasma, mixture of all that. And the Kupffer cell will be inside the sinusoid. So it is inside the sinusoid, but giving pseudopodia in the perisinusoidal space of Desaix. In the perisinusoidal space of Desaix you can have the stellate cell also, which is, let me zoom this little bit, the schematic diagram, and this stellate cell, which is ito cell, which is for vitamin A storage basically. So where do you find this stellate cell? Star shape in the perisinusoidal space of Desaix. And what is it doing there? It is for storage of vitamin A, plus it can form reticular fibers. It can form the reticular fibers. Reticular fibers are present in organs like lymphoid organs, and lymphoid organs could be, like we said, lymph node, it could be spleen, it could be liver also. So this stellate cell produce the reticular fibers, and reticular fibers can be seen in lymphoid organs like liver. Sometime if there is liver injury, it can produce more of reticular fibers, leading to cirrhosis of liver Or you can say in cirrhosis of liver, which is fibrosis of liver, which cell becomes pathologic? And it is stellate cell. Stellate cell can become pathologically activated to secrete more of reticular fibers, resulting in fibrosis or cirrhosis of liver. You know which lymphoid organ do not have reticular fibers? We said reticular fibers are present in lymphoid organs. Lymph node, spleen, can be the tonsil also. In tonsils, in lymph node, in spleen, in liver, you have reticular fibers. Which lymphoid organ do not have reticular fibers? Give me the answer. See, whatever I am teaching, these are all MCQs in the last 20 years of exam. Now some of the students will say, sir, why 20 years? Our teachers are telling last 5 years is enough. I've seen that is not a good approach. Though, of course, in the beginning you have to cover 5 years. Once you are done with 5 years, you increase the sphere of activity 10 years. Then you increase your sphere of activity 15 years. Then increase your sphere of activity 20 years. Why I'm telling you? Because now I am seeing some of the questions which used to come 20 years back, they have reappeared. I'll give you one example. Recently, hypogastric plexus, like total, there is a mesorectal excision of rectum. You want to remove the rectum, or you can say abdominoperineal resection of rectum, damage of hypogastric plexus. These questions used to come 20 years back. Then I'll tell you another. This is All India PG questions recently came. Portal hypertension, anastomosis between left gastric vessel, azygous vein. These are 20 years back questions. They have reappeared. So my point is, of course, if you do not have time, last 5 years, but if you have time, and you have to take your time out, you should be studying at least 8 to 10 hours per day before the exam. And if you can increase more than 10 to 12 hours per day, that is how you prepare for your exams like INI-CET or All India PG exam. So try to do as many MCQs as possible, and that is what we do. See, all my statements, all my discussions, they are based upon the type of questions which already have come and type of questions which are about to come in the next coming exam. And though it is quite amusing, so many faculties, they already have mentioned in the social platforms that they tell our accuracy is 70%, 80%, 90%, 96% accuracy, whatever they are teaching, and that kind of questions are coming. See, accuracy, you can be 100% accurate also. In fact, if you have taught the students last 20 years, previous year questions, then you are 100% accurate, because very few new questions come. So eventually it is nothing but the last 20 years previous year questions, which you have to master. You should start with 5 years, increase to 10, 15 and 20. I generally, my sphere of activity is 20 years. I can go beyond 20 also, but that is very ancient, archaic, archeo, and that is not needed. Okay, thymus. What about FMGE exam? FMGE exam is same pattern, but you have to score only 50%. So becomes a bit easier, but pattern is same. Don't be mistaken that they'll ask you simple questions. They appear simple, but you are marking them wrong. That is why you don't go beyond your target of 50%. So same type of questions come. Just the thing is, you have to just score 50%. That is the difference. Okay, so thymus, yes, you are correct. Thymus do not have reticular fibers. Now, if thymus do not have reticular fibers, then how do you suspend the lymphocytes? How do you suspend the lymphocytes? Because reticular fibers are needed to suspend the lymphocytes in lymph organs, maybe the lymph node or spleen or tonsil. Actually, in thymus, you do not have reticular fibers. Reticular fibers are nothing but type 3 collagen fibers. You take it from me, each of this is one MCQ, which already have come and is potentially a question to be coming in the next exam. So thymus do not have reticular fibers. Reticular fibers are type 3 collagen. But if they do not have type 3 collagen, reticular fibers, then how do they suspend the lymphocytes? Because thymus do have lymphocytes. In thymus, there is a special thing which is called as thymic epithelial reticular cells. Thymic epithelial reticular cells, they form the network to suspend the lymphocytes. And not only thymic epithelial reticular cells, they form the network to suspend the lymphocytes, basically the lymphoblast. They also help in training them as T lymphocyte. So thymic epithelial reticular cells, they are forming a network in thymus, obviously young people, not adult. Thymus is more active in young people, young girl or boy, and they'll be having lymphoblasts suspended, and they train the lymphoblast to become T lymphocyte, cell mediated immunity. You know who is giving this thymic epithelial reticular cells? They are coming from pharyngeal arches. And which pharyngeal pouch will form the thymic epithelial reticular cells? Tell me in the chat. In the chat, you are supposed to tell me, in thymus you do not have reticular fibers, but you do have thymic epithelial reticular cells, and they are forming a network to suspend the lymphoblast so that they can be trained as T lymphocyte. Which pharyngeal pouch will give you thymic epithelial reticular cells is my question. Pouch 3, yes. You should remember, mnemonic, you can say. Your mnemonic is PP3 tip. PP3 tip. PP3 is pharyngeal pouch 3. T is thymus. And what is IP? So thymic epithelial reticular cells, they come from pharyngeal pouch 3. Your mnemonic is PP3 tip. T is thymus. What is IP? Inferior parathyroid. And PP3 may be missing in DiGeorge syndrome. If it is missing in DiGeorge syndrome, then you will be having missing thymus. And if thymus is missing, then there will be deficiency of cell mediated immunity because T lymphocyte will be missing. So next time the question can be, thymic epithelial reticular cells derived from, your answer is endoderm of pharyngeal pouch 3. Endoderm of pharyngeal pouch 3. Now I'll ask you another question which already have come earlier. What about the connective tissue of thymus derived from? Because you have just told me thymic epithelial reticular cells, they are endoderm in origin, pharyngeal pouch 3. But what about the connective tissue of thymus? And if you remember, yes, PDF, I'll definitely give you PDF. There is no doubt. I'll make a PDF of this and give you the PDF. Don't worry. Just try to focus, try to understand how the examiner is thinking, because that is how you should be actually preparing for your exam. So, mesoderm, which mesoderm? Primary mesoderm or secondary mesoderm? So you have to remember, a question already have come. Thymus connective tissue is derived from. Your answer is thymic connective tissue is derived from mesoderm, but it is secondary mesoderm from neural crest cells. Neural crest cells. So thymus, there are two questions. Question number 1. Thymic epithelial reticular cells derived from. Your answer is endoderm of pharyngeal pouch 3. Next question. Thymus connective tissue is derived from. You remember most of the head and neck connective tissue is derived from secondary mesenchyme from neural crest cells. And I have seen some names given. During the chat, you have written some names. I guarantee you, 100% guarantee that faculty, most of the faculty in India, they don't know all this because they have never read it. They never read Gray's Anatomy. But your examiner, they belong to AIMS, they belong to JIPMER, they belong to PGI Chandigarh. Be careful. PGI Chandigarh, NIMHANS, And these are, especially in EMHANS and JIPMER, because my MBBS is from Bangalore Medical College. I have been trained in South India, and South Indians, they are very hardworking. They have immense knowledge. So the professors who are at EMHANS, at JIPMER, even at AIMS, AIMS is everywhere now. Though when we say AIMS, AIMS is New Delhi AIMS. There used to be one AIMS, but now AIMS is everywhere. These professors, their knowledge, depth of knowledge is too much beyond your comprehension, in fact. So don't tell me some names and this teacher is very good, this teacher is very good. Every teacher is good, but just look at their caliber. And look at the war which you are fighting for. You should be serious about almost everything when it comes to profession. You are going to become a doctor. You have license to treat, not license to kill. You're not James Bond, license to kill, not 7. Though you have license to kill, nobody will ask you. You can escape. But it is license not to kill, license to treat. And you should leave no stone unturned to increase your capacity, your knowledge. And these professors, they're not simple people. They have spent their whole lifetime teaching only. And they prepare all these questions. And don't think that they are useless questions. Though in our ignorance, we will think that this is useless. But they are never useless. We should respect our seniors. We should respect their decisions. And once you become knowledgeable, maybe, in the beginning you have to learn the rules. You have to follow the rules. Later you may bend the rules. But you are not at that stage right now. Right now you are a follower. You should follow the rules, learn the rules. And maybe later when you become more efficient, you may bend the rules. You may change the rules. A teacher will be very happy when he sees his student was capable enough to change the rules. But humanity is supreme. You should be very careful, very conscious, very sincere, very honest, very hardworking. You should be a good doctor. You should have ample knowledge. That is what I can say. Okay, this is one other question which came. They were asking about this cell. Can you identify this cell? This is respiratory tract. Pseudo-stratified ciliated columnar epithelium with goblet cell. These are cilia. This is pseudo-stratified epithelium. Goblet cells are there, empty looking, mucus secreting. Tell me which cell is this? It is seen in small lumen bronchiole. Small lumen bronchiole. Like terminal bronchiole. Respiratory bronchiole. But sir, questions asked from anatomy are less in last years. Why? No, I don't think. All the questions which have come in the recent years, they are all previous year questions. There are no new questions. There are very few new questions. When you are giving wrong answers in the repeat questions only, why should I prepare a new question? It's as simple as that. There are no new questions. Most of these are repeat questions. Club cell. Very good. Very good. So, this is club cell, or what you can say Clara cell. So this is a Clara cell or club cell. How do you identify the club cell or Clara cell? It is a cell which is bulging. It is a cell which is bulging into the lumen, and it is not having cilia. See, normally respiratory tract will be ciliated except for goblet cell or except for the Clara cell. And anyway, when you have Clara cell, you don't have goblet cells there at all. Goblet cells disappear almost. So, club cell is identified by the fact that it will not have cilia. It is dome shape projecting into the lumen, and it will have these contents, and that is nothing but surfactant, surfactant. You know surf is with which you wash your clothes, surface active agent to reduce the surface tension of alveoli, to prevent its collapse. So club cell or Clara cell is identified with the fact it will not have cilia, like normally the epithelium of respiratory system is ciliated. It will have a lot of granules, and those granules are surfactant lipoproteins, phospholipids, and they are important because they are going to reduce the surface tension of the alveoli, preventing their collapse. But in some conditions, like in COVID, or in a baby born before week 28, respiratory distress syndrome. So in respiratory distress syndrome, which can be a case of COVID, sometime it can happen, or a baby born less than 28 weeks, respiratory distress syndrome, the surfactant levels go down. Though surfactant is secreted by the Clara cell, club cell, mostly it is secreted by type 2 pneumocyte, but type 2 pneumocyte is not seen in the terminal bronchiole or respiratory bronchiole. The club cell, Clara cell are present in the terminal or respiratory bronchiole. Where is type 2 pneumocyte? Type 2 pneumocyte is not in the respiratory bronchiole, terminal bronchiole, it is in the alveolus. And most of the surfactant is given by the type 2 pneumocyte, but there will be a reduction of these surfactant, and that can be a problem. What is the other function of the club cell? Give me two more functions of club cell in the chat. In the chat, you are supposed to tell me two more functions of the Clara cell. Already MCQs. I don't speak anything beyond MCQs. My random access memory. In my hard drive, there is a lot of information, but I don't use hard drive to teach you people. I teach you from my random access memory. In my random access memory, whatever I speak is all MCQs. Already came, they are coming, they are about to come. So tell me the other functions of the Clara cell. They have stem cell. Stem cell actually is different. You cannot actually say Clara cell is a stem cell, but one function which you should remember is they are detoxification of the inhaled air. Whichever air we inhale, they help in detoxification. That is one of their function. They can work as stem cell, agree. But detoxification is one of their function. Okay, anyway. Now, yes, that is correct. Serotonin secretion is Kulchitsky cell. If you talk about the serotonin secretion, that will be Kulchitsky cell, neuroendocrine cell. They will give you serotonin. Stem cells are different actually, but it can work as stem cell. I agree. There is no doubt. Clara clear air, yes, I agree. Structural support, you have the other epithelial cells for structural support. Anyway, okay. Kem Samlapuram, very good. I used to go to Kem Samlapuram and I used to teach very hardworking, humble students. You know, South India, one good thing is they are very knowledgeable, very hardworking and very humble. There is a problem with North Indians that they, first of all, they are not hardworking. I belong to North India. So I am talking about myself. Maybe I am an exception. We are not hardworking, first of all. We are lazy people compared with South Indians. Second, our knowledge is not that good. We somehow manage. We jugaad techniques. We are very good at jugaad. Though, of course, if we don't have knowledge, then how can we manage patient? We will have knowledge, but not at par with South Indians. And number three, we are not humble. We are not humble. Our neck, our face, our nose is, if you want to learn actual Hinduism, then you go to South. They're very humble people, very knowledgeable, very hardworking, and I have been trained there. That is how I know them. I know Karnataka people, Hyderabad, Andhra people, your Kerala people, Tamil Nadu people. It doesn't mean that there are some bad people in UP or bad people in Delhi. Though Delhi people are very toxic people, take it from me. In certain aspects, everybody will have some. कोई भी दूध का धुला तो नहीं है. दूध का धुला कोई नहीं है. everybody will have some shortcomings and some good points. And if you don't want to be unhappy, if you want to be happy, just focus upon positives, don't focus upon negatives. But you should know negatives, that this person has these negatives. You should escape those negatives. Always think positive, talk positive, do positive, then you will be able to achieve your potential. But Kim Samlapuram I have always enjoyed. But one thing which I have never enjoyed is lot of chili in everything. Anything and everything, lot of chilies. Kim's Amlapuram, yes. Life teaches you a lot of things. I have seen bad days, good days. But anyway, you always learn, and you learn from your students actually, you know. A teacher should always be a student, and the best teacher for a teacher is his students. It is you who teach us. And the moment I stop learning from you, that will be the dead end of my progress. So you should always be in evolution. And I know nothing, in fact, because there is a famous saying, the more you read, the less you know. Because you become aware, otherwise you are ignorant. So the more you read, the less you know. Why do we say so? Because then you realize that you have been so ignorant. You know, each patient is different. You cannot apply the same principles on patients universally. Each patient is different. Each surgery which you do, maybe 20 surgeries you are doing, 21st surgery will be some anomaly. And you are a good doctor if you handle that 21st patient. 20 patient, nobody will praise you for what good you do, but they will haunt you for the bad you do. So your efficiency is that anomaly also you knew and you could handle in that state. So that is a good doctor. And that is what we want you to become. We don't want you to become some jhola chap people around us. Many of us are like that. But you should evolve actually. And as I told you, you should have a license to treat, not license to kill. Anyhow, the more I read, the less I know. I have realized that, not lately, but that is the truth. We are ignorant people. We think that we know everything, which is such a, falsehood. Our professors must be laughing at us. See what these people, they think they are. And one more thing, a question, because our discussion is for your exam, INI-CET exam, so I must not deviate from there. A question came. This is respiratory epithelium. First of all, you should know what is respiratory epithelium. Can you see that nuclei at various levels, though each cell touches the basement membrane. Each cell is touching the basement membrane, but the nuclei at different heights, pseudo-stratified. So this epithelium is pseudo-stratified, nuclei at different levels. Ciliated, these are cilia. Now, to identify cilia, you should know, you will have this thick pinkish line at the base, which is basal bodies, the centrioles, 9+2 arrangement of cilia. That is how they move. So cilia, they have 9+2 arrangement of centrioles. The basal bodies will give you a thin pinkish line. This thin pinkish line will not be seen in microvilli. I'll rub it off and show again. You see, we are talking about this thin pinkish line. Can you appreciate that line here? This line will be missing in microvilli. Microvilli only have some actin filaments going into, and they don't move. Microvilli is just to increase the surface area of absorption, like in small intestine, in PCT, DCT. In PCT, DCT, you have microvilli, brush border. In small intestine, you have microvilli to increase surface absorption, but they don't have centriole. So centriole mechanism is present only in cilia. to have mucociliary clearance, like mucociliary clearance of respiratory tube. You breathe air, there is some dust particle, bacteria, you want to cough them out, you have to move the cilia. They are also present in the uterine tube. In the uterine tube you will have cilia so that you can move the conceptus towards the uterus for implantation. Uterine tube cilia will have this thin pinkish line. That line is basal bodies, 9+2 centriole mechanism, because in uterine tube also you have to move the conceptus. It is moving towards the uterus. What will happen in Carter-Jenner syndrome? In Carter-Jenner syndrome, immotile cilia syndrome, chronic sinusitis, bronchiectasis, because you could not clear the bacteria. In Carter-Jenner syndrome, immotile cilia syndrome, you will have chronic sinusitis, bronchiectasis, and decreased fertility. Decreased fertility. Why decreased fertility in Carter-Jenner syndrome? Because conceptus could not reach the uterus. It was implanting in the uterine tube. Ectopic pregnancy, decreased fertility. Carter-Jenner syndrome can result in decreased fertility because immotile cilia are unable to move the conceptus towards the uterus, and if conceptus is not implanting in the uterus, if it is implanting in the uterine tube, ectopic pregnancy, reduced fertility is a feature of Carter-Jenner syndrome. But remember, Carter-Jenner syndrome, it is not included in triad. What are the three features of Carter-Jenner syndrome triad? This question comes. Carter-Jenner triad, what are the three features? One, I told you chronic sinusitis. The other, I told you bronchiectasis. What is the third one? It is not reduced fertility. If you read Harrison medicine, it will tell you. Tell me the third one. Dextrocardia, yes. Situs inversus. Situs inversus. It is situs inversus. Situs inversus means you can have the heart shifted to right side, spleen shifted to right side. But why the spleen shifted to right side? Why the heart shifted to right side? Because if it is Carter-Jenner syndrome, immotile cilia, embryonal cells, they need cilia to move. And because in Carter-Jenner syndrome, the cilia are immotile, embryonal cells, they are not moving properly. And organs are misplaced. Situs inversus. I'll repeat my information. First of all, if somebody asks you Carter-Jenner triad, immotile cilia syndrome, read Harrison medicine, it will tell you three things. Chronic sinusitis because you could not have mucociliary clearance. And then bronchiectasis, pus in the abnormal permanent dilatation of bronchus. What is bronchiectasis? Bronchiectasia. Bronchiectasia, dilatation of bronchus. Why bronchus is dilated? Pus collection. Why pus collection? Because you could not cough out the bacteria or the dust. But why situs inversus? Because embryonal cells could not move properly. Misplacement of organs, dextrocardia, spleen on the right side. What about the reduced fertility then? Of course, reduced fertility is a feature of Carter-Jenner syndrome, but not included in the triad. It is a feature of Carter-Jenner syndrome. Okay, other thing, one question came. It was asking about this basement membrane. There was a marker at basement membrane and there was a marker here. This is basically subepithelial connective tissue, which is also called as lamina propria. It will be some connective tissue, subepithelial connective tissue. So be careful in your exam. INI-CET exam, markers were marker A, marker B, marker C, marker D. One marker was on basement membrane and one marker was subepithelial connective tissue, which is lamina propria, and you should be able to identify them. Under epithelium there is always some loose areolar connective tissue. This is loose areolar connective tissue which is supporting the epithelium, and this is called as lamina propria. Most of the epithelial tissue will have a supporting lamina propria. So identification of these structures are important. A question came, it was asking about epididymis. In epididymis, do you have cilia? In epididymis, do you have cilia? Tell me. In epididymis, do you have cilia? In epididymis, you do not have cilia, it is stereocilia. So, is it moving? No. In epididymis, you do not have cilia, it is stereocilia, and stereocilia is nothing but like a microvilli. It is like a microvilli, means it will have actin filaments. You see, there is a difference. This is what you are calling as the cilia. This is cilia, and this is microvilli. In microvilli, what you have is actin filaments. Actin filaments. In microvilli, you have actin filaments. You do not have the basal body. So, this basal body or centriole is seen only in cilia. So, what about the epididymis? Epididymis is nothing but it is just, you can say long microvilli. Long microvilli, this is stereocilia, and they will also have what? Actin. Let me shift this here. So, where do you see cilia with basal body? Respiratory tract, uterine tube. And where do you see microvilli with actin filament? That is small intestine, PCT, DCT. And where do you see stereocilia? Stereocilia is not a cilia. Then what it is? It is a long microvilli. Longest of the three surface projections. Longest of the three surface projections means cilia, microvilli and stereocilia. The longest is stereocilia. And where do you see stereocilia? Stereocilia can be seen in the epididymis. And where else do you see? It can be seen in ductus deferens. And where else do you see? Inner ear. Inner ear. Inner ear also have stereocilia. So, inner ear have stereocilia. But why do you have stereocilia if it is not moving? It is just to increase the surface area of absorption. That is the purpose. What is the purpose of microvilli? So, epididymis, ductus deferens, inner ear, they will have stereocilia, which is not cilia, no. And it will have actin filaments, yes. And just to give some structural support, yes. And increase the absorption, yes. Okay. Endolymph, perilymph of the inner ear, yes. That is what we are talking about, endolymph, absorption. These are all MCQs. In my random access memory, there is all MCQs. And don't think that while teaching I am bringing up some of them right now. Impromptu. No, I have planned this. I have planned this class for last almost 10 days. 10 days back, they told me there will be a class. And I have been planning for this class for last 10 days. These are not randomly popping up some. Lot of hard work, lot of honest work, lot of sincere work with the humble pray that whatever I am teaching should come in the exam, should help you. That is the ultimate purpose of any class. Otherwise, what are we doing here? So here, another question has come in histology. How do you identify type 1 or type 2 alveolar cell? Alveolar macrophage, which is dust cell. Dust cell. So question came for dust cell. Macrophages, again, it is a tissue resident monocyte phagocyte system, like Kupffer cell. There is a Kupffer cell in liver, there is a dust cell in lung. They are monocyte phagocyte series. Pseudopodia eat whatever is there. Dust cell, they whatever we breathe, there is dust, they will take the dust cell. Large cell with lot of inclusions, and dust cell can be in the lung alveoli or in the wall of the alveoli. It can be in the lumen of the alveoli. It can be in the wall of alveoli. Though wall of alveoli, mostly you will have this, you see, flat cell with flat nucleus, type 1. Flat cell with flat nucleus, type 1. Simple squamous epithelium. Simple squamous epithelium, so that you can have what is called as rapid O2 CO2 transport, because in alveolus you have O2, you have to take it to the capillaries, and from capillaries you have to give CO2 to the alveolus. So type 1 pneumocytes, they will be thin cell, simple squamous epithelium with flat nucleus, compared with type 2 pneumocyte, which you see here now. You will find type 2 pneumocyte is here. It is spherical nucleus. So as we tell, it is a cuboidal cell. Height equal to breadth, spherical nucleus, type 2 alveolar cell, and secreting the surfactant. So type 2 cells will be giving us surfactant. They are very few as compared with the lining of the alveolus. In lining of alveolus, mostly it is type 1 cells which are involved in O2 CO2 transport between capillaries and the lung alveoli. And the purpose of this showing you this diagram is should know how the macrophages will appear, because they actually gave you one electron microscopic picture. This is INI-CET exam, they gave you an electron microscopic picture, and maybe this will help you. A type 1 pneumocyte will be a flat cell with flat nucleus because it is simple squamous epithelium, and the type 2 pneumocyte will be having lamellar bodies. These are what you call lamellar bodies. The lamellar bodies, because lamellar bodies is surfactant, a large cell comparatively compared with type 1, and spherical nucleus, cuboidal, because it is. This is simple squamous, this is cuboidal, and this is the macrophage. Macrophage is largest of all these cells, and it will have pseudopodia, and it will have a lot of inclusion, and this is capillary. Capillary epithelium is again endothelium. Endothelium is simple squamous. So capillary epithelium will be simple squamous, and which we are talking about here. This transport means from capillary you give CO2 into the alveolus, and from the alveolus you take O2 back into the capillaries. Respiratory membrane, respiratory gas exchange happens through a thin cell which is type 1 pneumocyte. Okay. Now we are moving on to neuroanatomy, and I'll be marking one thing. You identify what I have marked. What is this? I have marked. Gillual cell. What is this? Please tell me gillual cell. What is this gillual? I have not known this cell. Gillual cell. I'll find out. I'll find out. Gillual cell. That is what? We are so ignorant. We think that we know everything, but we know nothing. No, it is not septum pellucidum. Fornix. Okay, you have identified fornix, fine. Now tell me which kind of fibers it is having. The commisural fibers, association fibers, or projection fibers. So you already have identified that this is fornix, and if you are talking about septum pellucidum is here. This is septum pellucidum. This is septum pellucidum, which is separating lateral ventricle from lateral ventricle. Lateral ventricle separated by septum pellucidum, but attaching to septum pellucidum is fornix. Let me demarcate the fornix here. Say, let us choose some color which is evident. This is one-sided fornix, that is the other-sided fornix. This is one fornix, that is the other fornix. There are two fornixes fused here. So that is fornix, that is, if you are talking about septum pellucidum, it is here. This is septum pellucidum. And if you are still looking above that, this, then it is corpus callosum. This is corpus callosum. So, what is attaching inferiorly to corpus callosum is septum pellucidum. What is attaching inferiorly to septum pellucidum is the fornix. Now, I am asking you, fornix has which kind of fibers? Is it commissure, association or projection? Actually, all the three. If all the three, then what should I answer? Commissure is first answer, association is next, projection is next. Cap, you can remember cap in a sequence. Cap in a C for commissure, A for association, P for projection fibers. So first of all, you should say commissural fibers. What is a commissural fiber? Like corpus callosum is a commissural fiber. Cross the midline and connect the right brain with left brain. That is commissural fiber. Now, if you are telling that these are all axons, white matter axons. So fornix or corpus callosum, fornix is connecting right frontal lobe with left frontal lobe. So crossing midline, connecting one lobe of brain with the other, right with the left lobe. What is the fornix connecting then? One hippocampus with other hippocampus. You connect the right hippocampus with left hippocampus using the fornix. That is what? Okay, then why would you call it as association fiber? What is association fiber? Association fiber is, let me show. Do not cross the midline, keep connecting one part of brain with the other on the same side. So, if you are talking about the association fibers, they do not cross the midline, they keep connecting brain on the same side. For example, arcuate fasciculus connecting Wernicke's area with Broca's area on the left side. So Wernicke's area, Broca's area, you are connecting on the left brain, it doesn't cross the midline. Arcuate fascicle is association fibers. So when you are talking about the association fibers, one of the example could be arcuate fascicle, which is connecting Wernicke's with Broca's. So do you mean to say fornix has association fibers? Yes, fornix do have association fibers. It keep connecting the parahippocampal structures. Hippocampal, parahippocampal structure, it will connect them on the same side, So hippocampal, parahippocampal structures connected, so association fiber, yes. And how is it projection fiber? It is a projection fiber like internal capsule. You see, internal capsule is a projection fiber. Let me show. This is the internal capsule. This is internal capsule. How do you know this is internal capsule? I know this is internal capsule because this is the thalamus here. This is the lentiform nucleus there. This is the lentiform nucleus here. This is the thalamus here. So what is between the two is the internal capsule. This is internal capsule. This is internal capsule. It is a projection fiber. So this thalamus medially, lentiform laterally, and this is internal capsule. But what is internal capsule? It is a projection fiber. What is a projection fiber? Projection fiber connecting upper brain center with the lower brain center. So projection fiber is connecting upper brain centers with lower brain centers. That is a projection fiber. Are you telling that fornix is also a projection fiber? How? Because it will connect hippocampus with mammillary body. It is connecting hippocampus with mammillary body. So connecting higher brain center with lower brain center. Yes, it is a projection fiber. So a question can come on fornix, identify which kind of fibers. It is commissural, it is also association and projection. And if you are talking about internal capsule, then it is projection fiber connecting upper brain center with lower brain center and lower brain center with upper brain center. It can be motor fibers or it could be sensory fibers. We will use this diagram once again, but at this moment, you are looking at a sagittal section of the brain, anterior, posterior. You have removed this half of the brain and looking at the left half of brain now. So it is a sagittal section. You have taken an anterior posterior section. You have removed right half of the brain and looking at the left half of brain from the medial view. I will be marking a structure and you identify what it is. What is this? What is this? Because again, in the exam, you are getting such questions. If neuron cells do not regenerate, then how the brain cause cancer? Astrocytes, astrocytoma. Astrocyte is not a brain cell as such, neuron cell. Oligodendroglioma, connective tissue tumors. Fornix, yes. And fornix has which fibers? First answer should be, it is a cap. First is commissure, connecting one hippocampus with other hippocampus. Now if you say fornix is a commissural fiber connecting one hippocampus with other hippocampus, where is hippocampus? Again, one MCQ. All the statements which I speak in class, they are all MCQs. Where is hippocampus? Hippocampus is present in inferior or temporal lobe. It will be in the inferior or temporal lobe. So hippocampus is in the inferior temporal lobe. This is fornix. What is the association? Association is fornix is connecting one hippocampus with the other hippocampus. It is commissural fiber. But then you told that it is also association fiber. Yes. Because it will not only connect hippocampus, it will also connect parahippocampus. Para means around the hippocampus. Hippocampus, parahippocampal connected. So association fiber without crossing the midline. Without crossing the midline, association fiber. And what about the projection fiber? You told it is projection fiber also. Yes, projection fiber. How it is projection fiber? Because it is projecting the information from hippocampus towards mammillary body. Mammillary body. This is mammillary body. What is it again? Hippocampus. The major output is fornix. Major output, or what you say, efferent. Efferent is exit. E for E, exit, output. So a question comes, what is the major output tract of hippocampus? The major output tract of hippocampus is this, the fornix. And where is it taking the information? To this. What is this? The mammillary body. Sir, you have already drawn, we cannot see. Yes, you cannot see, I'll rub it off and then you can see. This is the mammillary body. And what is mammillary body basically? Hypothalamus. Hypothalamus. We are talking about a circuit which is called as Pape's circuit. And a lot of questions are coming on Pape's circuit. In Pape's circuit, you will have these connections. In Pape's circuit, you will have to talk about hippocampus, you will have to talk about fornix, you will have to talk about the mammillary body, and you will have to talk about a structure above the corpus callosum. What is the structure above the corpus callosum? Name it. Part of Pape's circuit. Name it. Name this structure which is above the corpus callosum, is a part of Pape's circuit. Tell me. Yes, cingulate gyrus. Cingulate gyrus. Tell me the function of cingulate gyrus. Tell me the function of cingulate gyrus. There can be many functions. It is a part of cerebrum, basically, part of cerebrum. But one thing is satisfaction. Satisfaction. So cingulate gyrus is related with satisfaction. What kind of satisfaction? See, satisfaction could be anything, but since you are talking about Pape's circuit is limbic system. And you tell me what is the purpose of limbic system? So there is one limbic system. In limbic system there is a Papage circuit. What is the purpose of limbic system? What is the purpose of Papage circuit? What is the purpose of cingulate gyrus? Limbic system is very old primitive system. You know, we were animals, then we became humans. But we have animal instincts. What is animal instinct? Animal instinct is, the very first animal instinct is to survive. And the second is to perpetuate, make more of us. So animal instincts, basic instincts. Have you seen the movie Basic Instincts? Your limbic system is working, Papage circuit is working, that satisfaction thing is working there. It is first of all food to survive and sex to make more of us. Food and sex. And that after having food, what do you get? Satisfaction. Though satisfaction can be at various levels, but one of the satisfaction deriving factor is the cingulate gyrus. Cingulate gyrus give you satisfaction of food and sex. You can mention like that. So when we have food and we have sex, then we will be satisfied. Of course, otherwise, okay, leave it. So this is the introduction. Let me take you to the actual diagram now. Can you tell me how many questions have come on whatever I told here in last 5 years, maybe last 10 years? How many questions? At least 50 questions, 50. In last 10 years, almost 50 questions, because I write a book, Self-Assessment and Review of Anatomy, JP Publications. I go through all the previous year questions, and I was just counting in last 10 years, how many questions have come on Papage circuit, limbic system, components? 50 questions, 50. So will they stop coming now? No. Because recently they have asked amygdala is a part of Papage circuit or limbic system. So this is what we call as ignorance. We think that we know everything, but you know nothing. Examiner will prove this at every stage of your life, that you know nothing. And that is how we learn more. So I did not know, actually. I thought amygdala is a part of basal ganglia because it is written in Gray's Anatomy. But once the question came, I could see that amygdala is also a part of Papage circuit, limbic system, and which is, so there is no end to knowledge. Now you might wonder then what is the use of knowing about amygdala there, because there are cases. It is something which is related with deep emotions, and deep emotions, what is the best emotion you know of in the chat? What is the best emotion you know of in the chat? Why only food and sex, not water or air? Of course, gentleman, or I don't know, anon must be a male. So yeah, of course, we need air and we need water, yes. I cannot disagree with you. Anyway, yes, fear. Dr. Ashish, fear. Love, romance is a very good emotion. Romance is the best emotion you can ever feel in your life. But it happens only once. फिर दिल टूट जाता है, फिर तो फॉर्मेलिटी है उसके बाद सब. जो पहली मोहब्बत है वही याद रह जाती है, बाकी सब तो फिर चलो ठीक है कर लेते हैं वगैरह वगैरह. और बड़े ही lucky, there are very few lucky people who would be having their first love throughout their life with them. But the emotion, the extreme emotion is fear actually. And this structure which you are talking about, amygdala, is very much related with fear. Survival, you know, survival. In survival, the first thing is fear, then comes the sex. Anyway, so what about this limbic system? What is the purpose of limbic system? See, when we talk about the limbic system, first of all, you have to understand it is something to do with memory. Then it is the smell. Then it is the motivation. So memory, smell, motivation, all that, which is important for survival and perpetuation of species. So limbic system is all about survival and perpetuation of species. You survive by taking food and you perpetuate by having sex, and it is later with memory. Memory will modify your behavior, your motivation, and smell is also related. Smell is a very powerful emotion which relates with memory. Now it begins with hippocampus. Hippocampus is the seat of short-term memory, and if you want to convert short-term memory into long-term memory, you will use the fornix. Fornix, as we told, it is the major output tract from the hippocampus. Now we are focusing upon the Pepys circuit. So as you see, first of all, we should talk about hippocampus. Hippocampus is basically part of Pepys circuit, which is limbic system, and it is for short-term memory. For example, what food did you take yesterday lunch? Yesterday in lunch, what food did you take? Sir, I took nothing, I was on fast. Yes, but you remember that, isn't it? So that is your short-term memory. And which food did you take last year, September 13th dinner? Sir, last year, September 13th dinner? How can I tell? You could tell because you were with your girlfriend, you were having a dinner, and she had some very nice perfume. Now you will remember. Yes, sir. Last year, September 13th, dinner I had with my girlfriend, and we were having this and that. How do you remember that? Because consolidation of memory. So when you convert short-term memory into long-term memory, that is done by fornix. Fornix is to convert short-term memory into long-term memory, and it is very much related with smell, perfume of your girlfriend or boyfriend, vice versa. Anyway, hippocampus, the major output tract is fornix. And where is it sending this information to? Mammillary body. You have learnt the projection fiber. This is the projection fiber, connecting higher brain center with lower brain center or vice versa. This is projection fiber. So mammillary body, where is mammillary body? It is hypothalamus, and now it is connecting with thalamus. Thalamus also anterior nucleus and mammillothalamic tract. Among you, there are some students who have practiced previous year questions, they will know that these questions have come rampantly, frequently, every other exam they are asking. So mammillothalamic tract is what? Coming from mammillary body to the thalamus, mammillothalamic tract. So mammillothalamic tract is connecting hypothalamus with thalamus. Yes, hypothalamus with thalamus, and then there's thalamus, which is anterior nucleus of thalamus, because thalamus has many nuclei, one of them is anterior nucleus. Will send it to cingulate gyrus. You have known that cingulate gyrus is present in the cerebrum. It is in the cerebrum, and it is for satisfaction. We have discussed it is for satisfaction. That satisfaction could be due to food or sex or whatever. And then the pathway comes back into hippocampus. It is a complete neural loop, and it keeps on going around and around. So it is a neural loop, goes around and strengthening your memory and your behavior, your emotions, and your smell also relates here, which is missing from here. You can add here, after cingulate gyrus and before hippocampus, there is entorhinal cortex. Entorhinal cortex. Rhinal means nose, smell. So if you want to complete Pepys circuit, there are a lot of intermediaries. I have added one. After cingulate gyrus, you have to go to entorhinal cortex. Entorhinal cortex, smell pathway. Your girlfriend or boyfriend having that particular perfume. And then hippocampus. So what is the purpose of this? limbic system. This is limbic system, of course, and limbic system is for survival and perpetuation of species. Now, once you have known this, let us demarcate all that in this diagram also. This is a loop which goes on and on. Let me show you the loop now. It starts with hippocampus. What is the location of hippocampus? Inferior temporal lobe. Inferior temporal lobe. Okay, then from hippocampus, where it goes? From hippocampus, it will go via fornix. This is fornix. Okay, via fornix, where is it going? It's a projection fiber. It will project to hypothalamus, mammillary body. Hypothalamus, the mammillary body. And from hypothalamus, where it will go? Mammillothalamic tract. This is thalamus. In thalamus also, anterior nucleus of thalamus. Anterior nucleus of thalamus. So this is mammillothalamic tract. Yes, that is mammillothalamic tract going to anterior nucleus of thalamus. And from there, where it will go? From there, you will find, so from the hippocampus, the fornix, to the mammillary body, the hypothalamus, then mammillothalamic tract to the thalamus, anterior nucleus, and from there to cingulate gyrus, which is above the corpus callosum. So above the corpus callosum, you are having this. What is this? The cingulate gyrus. And from cingulate gyrus, where the information will go? From cingulate gyrus, the information is now coming to hippocampus again. Coming to hippocampus again. Now, if it is coming to hippocampus again, it is a loop basically. Yeah, it is a loop. Hippocampus, fornix, to the mammillary body, to the thalamus, to the cingulate gyrus, and back to the hippocampus. It goes round and round, consolidation of memory, integrating memory with the smell. But where is smell pathway here? Smell pathway is here. Olfactory bulb is for smell. And there is an entorhinal cortex. And this is the entorhinal cortex. Entorhinal cortex in the temporal lobe. The temporal lobe under uncus. Uncus. Deep to uncus. So deep to uncus in the temporal lobe. In the temporal lobe where I have the hippocampus also. Yes, hippocampus is in the inferior temporal lobe. One MCQ, it already is. And then came an addition. I told you very rarely a new question will come. And it has come. This question never came. They have never asked. As per my knowledge, maybe they have asked, I have missed it maybe. But recently they asked, is amygdala a part of limbic system? And you have to say yes. Now, if you ask me, is there anything left now so that I can add in limbic system? Yes, read Gray's Anatomy. And then you will know that you know nothing. That is the depth. Sir, even after teaching so much on your limbic system, Papage circuit, you are telling that there is still more to explore. An examiner can explore and ask some question which is new. Yes. That is why I told you, the more I read, the less I know. And then we think that we are James Bond. We know everything. No, we know nothing. And this you will realize when you lose a patient on your OT, on your operation theatre table. When you lose a patient, then you will realize that you know nothing. You are at the mercy of whatever supreme power is there. You may call it as God or whatever, nature, but you are at their mercy. So you should leave no stone unturned to continuously evolve yourself, work hard, because it's a long journey. You are a doctor. You are bound to make mistakes. And making mistakes is not a problem. Don't make blunders. Everybody makes mistake. To err is human, but don't make blunders. So what is a blunder? Blunder is making a mistake knowingly. Knowingly you make a mistake. Say for example, you are coming out of exam hall, very happy. Oh, I have answered almost all the questions, very happy, my rank will be so and so. And one step out of your exam room after the exam, and a friend of yours passing by, that question was there, I have answered that particular question like this, and you realize, oh my God, I made a mistake. How could I make such a mistake? That is your blunder. An answer which you knew but could not answer properly. A mistake which is actually not a mistake. Despite knowing if you make a mistake, it is a blunder. The next step out of the room, another one, somebody telling that question I answered this one, and another blunder. Third step, fourth step, fifth step, and 5 blunders, and then your happiness on the face turns into gloom. How do you reduce these blunders? How do you reduce these blunders? Our purpose is just to reduce these blunders. The less blunders you make, the best rank you will get. And there is only one way to reduce those blunders. Practice previous year questions as many as possible, as many times as possible. So keep practicing previous year questions as many as possible, as many times as possible. Reduce those blunders and take it from me. I was watching all these people who got good rank in All India PG, and in the first, second interview, after that they become James Bond. That is a different story. But in the very first, second, third interview, when they were actually realizing that they have got a topper rank and they were just coming into that stardom. After stardom, everybody is what? I am a James Bond here. Ask me anything. I knew everything. I don't make any blunders. But just meet them. They have just got, their response is, oh, how could I get this rank? This is so funny, So what is this? Why these people are like this? Because that is the reality. Even they made blunders. Even toppers make blunders. But they make less blunders. That is the point. And how do they make less blunders? Because they keep practicing previous year questions. That is how. You may disagree with me. You may disagree with me, but I have seen life through all the stages. When I gave my exam, when I could not succeed in my first attempt, then I succeeded. Then I saw people succeeding. Then I saw them apprehensive. Then I saw them becoming James Bond. It is not that they are not capable. Every human is capable. We are equally capable. It's determination, how strong your determination is. Everybody is equal. God made everyone equal. It is your determination which differentiates between people. Anyway, now a question came. It was asking direct pathway in basal ganglia. Direct pathway in basal ganglia, because you have to understand we are preparing for INI-CET exam and we have to take care of those repeat questions. So direct pathway of basal ganglia, and I have rarely seen that somebody giving you correct answer, though I could see Dr. Marwa teaching medicine, he could reach good answer, and one of the student who gave the exam and he was giving correct answer. Otherwise I have seen most of the faculty could not reach the correct answer, and I had to read some physiology books to reach the correct answer. But anyway, let us talk about that. So basal ganglia, what is the function of basal ganglia? What is the function? And again, these are, see, the topic which we take here are very repeat question, often repeat questions, and they are going to get repeated very frequently, and that is the purpose of this class. So basal ganglia, what is the purpose is, what is the function? Planning and programming of voluntary motor activity. Planning and programming of voluntary motor activity so that the activity should be smooth. It should be smooth and it should not be jerky. It should not be jerky. That is the purpose. So basal ganglia, the planning and programming of voluntary motor activity, which is smoothening of that activity, and it should not be jerky. For example, you are given a thread and a needle on the table. On the table there is a thread, there is a needle, and the examiner is asking you, thread the needle, thread the needle. That should be a smooth movement. It cannot be jerky movement, isn't it? But sometimes it can become jerky, like in Parkinsonism. And if it is Parkinsonism, you know, Parkinsonism is identified by the fact tremors, rigidity, hypokinesia. There will be tremors, rigidity and hypokinesia. And these people cannot, of course, thread a needle. How can you thread a needle when you are having a pill rolling tremor? Pill rolling tremor or rigidity, cogwheel rigidity or lead pipe rigidity. So, pill rolling tremor, cogwheel or lead pipe rigidity, these are the problems these patients can have. Parkinsonism, a question has come in All India PG this time. They are asking about, so tremors, which is pill rolling tremor, how can you put thread into needle like basal ganglia disorder, and rigidity, which could be cogwheel or lead pipe, cogwheel type rigidity or lead pipe continuous resistance or hypokinesia. Mask like facies, mask like facies. Let me show you the diagram itself. They will have a very shuffling gait, they will have, gait is a shuffling gait. So, mask like facies, expressionless face, no expression of happiness, sadness, that expressions are lost. Pill rolling tremor, stooping, flexion posture, and difficulty to initiate a movement, and once a movement is initiated, difficulty to stop the movement. So, first of all, they keep thinking that I'll have to walk, and once they start walking, they cannot stop. So, these are features of basal ganglia disorder, and if you are in the wards, you must have seen one patient or two, and that is what the examiner is asking. In your exams these days, lot of clinical questions are asked, and which is good, at least you will attend your internship. Anyway, so as you talk about all these things, can you tell me the three structural component of basal ganglia? Three structural component of basal ganglia, because basal ganglia belong to telencephalon anatomically, embryologically. So, anatomically, embryologically, the basal ganglia is a part of telencephalon. So, what are the three component of telencephalon of basal ganglia? Structural nuclei. And if you want to look at that structural nuclei, one of that is the caudate nucleus. Caudate on left side, caudate on right side. So, one of that is caudate nucleus. Okay, what is the second one? Second one is, you can see here, is the putamen. This is putamen. And what is the third one? The globus pallidus. Globus pallidus. So, this is putamen and that is globus pallidus. Together they are called as the lentiform, because lens shaped nucleus. So, these are the three structural component of basal ganglia: caudate nucleus, putamen and globus pallidus. On that side section is oblique, so details are not that much clear, but on this side it is clear. Okay, so you have discussed the three structure. What are the two functional nuclei of basal ganglia? Functional nuclei. Functional means they are not part of telencephalon. Caudate, lentiform, this putamen globus is telencephalon, but there are two functional nuclei of basal ganglia which are not belonging to telencephalon. They belong to diencephalon and mesencephalon. Diencephalon and mesencephalon. In diencephalon, you will have the subthalamic nucleus, diencephalon, and in the mesencephalon you will have substantia nigra, mesencephalon. So, subthalamic nucleus under thalamus here, yes, because it is under thalamus, that is why it is called as subthalamic nucleus. So, this is number 1, this is number 2 and this is number 3, yes, and then this is number 4 and this is number 5, yes, 5 nuclei in basal ganglia. So, these are the 5 nuclei in basal ganglia: caudate nucleus, putamen, globus pallidus, structural, they are telencephalon, but subthalamic nucleus is diencephalon and substantia nigra is mesencephalon, midbrain. Substantia nigra identified by the fact that it is black stains, neuromelanin, black stains neuromelanin forming dopamine. It forms dopamine. If there is a problem with dopamine, you will have Parkinsonism. And you will treat the patient with L-Dopa. So substantia nigra identified by the fact that there are some dark stain, and that dark stain is neuromelanin, and that neuromelanin is the one which is related to formation of dopamine. Substantia nigra has dopamine, which is important, and if you have less of dopamine, you can have Parkinsonism. This is the basics. Actually, less of dopamine means more of acetylcholine in central nervous system. If you have lesser dopamine, it means more of acetylcholine. That is why treatment, you have to give L-Dopa and you have to give anticholinergic like trihexyphenidyl. You can give trihexyphenidyl, which is centrally acting anticholinergic for Parkinsonism. So Parkinsonism, as dopamine goes down, relatively centrally acetylcholine goes high. So if you want to treat your patient, first you have to give more of L-Dopa, increase dopamine as a treatment, and to take care of that elevated level of acetylcholine, that is why the tremors, rigidity come, you reduce them. How? By centrally acting anticholinergic like trihexyphenidyl can be given. Anyhow, now what about that direct pathway we were talking about? Direct pathway which the examiner has asked. So for that purpose, let me take you let us make use of this one to discuss the direct pathway. What happens is, this is direct pathway which question has come in basal ganglia. They were asking sequence 1, 2, 3, 4, 5 in sequence, tell. So it starts with the substantia nigra. Starts with the substantia nigra. Substantia nigra is number 1. It is number 1, and it will be giving us it will go towards the caudate nucleus. It will be sending information towards the caudate nucleus, of course using dopamine. Dopaminergic receptors are there on caudate. So number 1 is the substantia nigra, and number 2 is the caudate nucleus. Caudate. Then this is positive. It is stimulatory. It is positive. But then, as the caudate nucleus will send the information further, say it is sending it now to globus pallidus. Globus pallidus is third one. This is inhibitory. This will be inhibitory. And then globus pallidus will send this information further to thalamus, which is again inhibitory. To thalamus, which is number 4, which is inhibitory. So I'll repeat. Number 1, substantia nigra. This is direct pathway in basal ganglia. So number 1 is substantia nigra using dopamine, which is excitatory to caudate nucleus. Caudate nucleus is inhibitory to globus pallidus. Globus pallidus is inhibitory to thalamus. But then, if you are inhibitory, ultimately minus becomes plus, and thalamus stimulates the cerebral cortex. It will stimulate the cerebral cortex. So direct pathway is stimulatory. Now once the direct pathway is stimulatory, the movement whichever is happening by the cerebrum using pyramidal tract, that will happen. So I'll repeat once again. They were just asking the sequence. Sequence is number 1, substantia nigra, which is excitatory to caudate nucleus. Number 2, from caudate to globus pallidus, which is inhibitory. From globus pallidus to the thalamus, it is again inhibitory. But 2 inhibitories will make it minus minus means plus. So thalamus becomes stimulatory. It is actually stimulatory to cerebrum, so it will work as stimulatory to cerebrum. And in cerebrum, which area it is activating is a question. It activates the area post central gyrus Broadband number 4. Post central gyrus Broadband number 4. There is a central sulcus. So post central gyrus, not post, pre central gyrus, sorry. So pre central gyrus, area number 4, and pre central gyrus, area number 4, that is frontal motor cortex, will use the pyramidal tract and move the movement like threading the needle. Threading the needle. You wanted to thread the needle, so movement will happen. It is stimulatory for the movement. Basal ganglia is what? It is for smooth movement. So this is what I wanted you to understand and remember. Now we need to move on to head and neck region, some details. Let me just see what is the time now. 6:28. We started at 4. 2.5 hours already gone. Okay, so in the head and neck region, we are moving on to the pharyngeal arches, and a lot of details to discuss here. Looking from the side view, developing baby, U-shape arches, anterolateral, anterolateral, anterolateral in the head and neck region. So there will be 6 pharyngeal arches. In the 6 pharyngeal arches, 5th is rudimentary. They represent the gills of fish, but humans do not have gills, so they will have pharyngeal arches. So it is anterolateral, anterior and lateral, U-shape, 6 arches, 5th is rudimentary. They represent gills in fish, but in humans they are pharyngeal arches. And they'll be outside lined by ectoderm, inside ectoderm like skin, inside they'll be lined by endoderm of the pharynx, and between the two there'll be mesoderm. So if you take a section, you will understand the details. Like here we have taken a section. As you take the section, you can see for yourself that this is pharynx basically on the inside, so endoderm, and there will be some pharyngeal pouches developing. So pharyngeal pouches will be lined by endoderm on the inside, but if you look on the outside, ectoderm, there will be pharyngeal cleft. So you can see there will be pharyngeal cleft 1, cleft 2, cleft 3, cleft 4. So 4 clefts on the outside, lined by ectoderm. This orientation, after taking a section, you can draw yourself also. So as we draw this diagram ourselves, what we are doing is we are looking from, say, floor of the pharynx. It is like you have taken a section in the developing head neck, and you are looking at the floor of the pharynx like this. Because pharynx is here, you have cut a section, removed the anterior part, remove the posterior part, because you have to look at the anterior part, floor of pharynx. So looking at the floor of pharynx, this is pharynx. Pharynx is gut tube, so it is lined by endoderm. Pharynx is gut tube, so it is lined by endoderm, and we are looking at the floor of pharynx. Now the first layer to come is endoderm. Which comes after that is mesoderm. So this is the next layer, which is mesoderm. And which is the last one to come? Last one to come is here, the ectoderm. So this is the last one to come, which is ectoderm. And then you will see that there are some changes happening. The changes are in the inside, on the inside, there will be pharyngeal pouch 1, 2, 3, 4, right side and left side. So this is pharyngeal pouch number 1, 2, 3, 4, of course lined by endoderm. And then there will be pharyngeal cleft, which are ectodermal, 1, 2, 3, 4. Pharyngeal cleft number 1, 2, 3, 4 on the outside, lined by ectoderm. So cleft number 1, 2, 3 and 4. In the lateral wall of pharynx, you have pharyngeal pouches lined by endoderm. Then there is mesoderm, and then outside you have clefts which are lined by ectoderm. Now this mesoderm, which is here, is secondary mesoderm, and because it is head and neck region, it is secondary mesoderm. Where it would have come from the fourth germ layer, and that fourth germ layer is nothing but the neural crest cell derived secondary mesenchyme. So this mesenchyme will be neural crest cell derived secondary mesenchyme. That is why when we were talking about thymus connective tissue is from neural crest cells. But thymic epithelial reticular cells, they are from endoderm. Now what happens is cleft number 1 becomes the external auditory canal lined by epithelium, which is surface epithelium, ectodermal epithelium. Not only this side but also that side, because we have external auditory meatus on both sides, of course. So cleft number 1, what happens is pharyngeal cleft number 1 becomes external auditory meatus lined by surface epithelium, surface ectoderm. Otherwise cleft number 2, 3, 4 they get obliterated. Now how cleft number 2, 3, 4 get obliterated is by the growth of second arch mesoderm covering it and obliterating it and fusing with what is called as cardiac mesoderm. Cardiac mesoderm. So what is happening? What is happening is second arch mesoderm overgrows on this side, on that side also. Second arch mesoderm will overgrow and fuse with cardiac mesenchyme. So cleft will be obliterated, and as the clefts are obliterated, what happens is there will be a formation of branchial sinus, and then it will become branchial cyst, and then it will disappear. So what is the first thing we have? Cleft number 2, 3, 4. And what happens to cleft? They get obliterated. But as they are obliterated, they become branchial sinus, and then they become branchial cyst, and then it will disappear. What is the difference between sinus and a cyst? Sinus will have one opening. Cyst will have no opening. So sinus will have one opening and cyst will have no opening. So initially there will be one opening, but that opening will also disappear, so it will become cyst, and then cyst will also disappear. If the cyst is persisting, there can be congenital anomalies called as branchial cyst. So a question can come, branchial cyst is lined by which epithelium? Branchial cyst is lined by which epithelium? Of course, the epithelium of pharyngeal cleft. And what is pharyngeal cleft lined by? Ectoderm. So branchial cyst, which is an anomaly, normally it should disappear. If it is persisting, it will be lined by surface ectoderm, surrounded by mesoderm. Surrounded by mesoderm but lined by ectoderm. So that is branchial cyst. Sometime it can open into second pouch, tonsillar fossa. Sometime it can open into second pouch, tonsillar fossa. You say internal branchial sinus, because it has one opening. Internal branchial sinus, it has one opening, or it can open outside on the skin also. Here, skin of lower neck. Skin of lower neck, you must have seen branchial fistula. That will be external branchial sinus if it is cyst to the outside. But if you have one sinus here, two openings, then it will become a branchial fistula. So there can be just a cyst branchial cyst, or there can be internal branchial sinus, or there could be just external branchial sinus, just an opening on the skin, or there can be both. Internal branchial sinus plus external branchial sinus together becoming branchial fistula. So a question came, branchial, this is recent questions, very recent. Branchial fistula is, or branchial cyst, branchial fistula, branchial anomalies mostly belong to which arch? Your answer should be mostly they belong to second arch. They are mostly second arch anomalies, 90 to 95% of the cases. So clinically 90 to 95% of cases it belongs to second arch. Question was, branchial fistula is anomaly of which cleft? Branchial fistula is anomaly of which cleft? Or branchial cyst is anomaly of which cleft? Or it is due to unobliteration of which cleft? Of course, it is on obliteration of cleft number 2, 3, 4. But if you have to choose between 2, 3, 4, then 2 is your best answer, according to the literature. Okay, now that is about the cleft. What about the pouches? Pouches, you can tell. In here, pouch 1 will form, you can show here, middle ear cavity and eustachian tube. So what is pouch number 2 doing? Pouch number 2, you can see for yourself, will form the middle ear cavity and eustachian tube, epithelium. So pharyngeal pouch number 2 will form epithelium of middle ear cavity and eustachian tube, lined by which germ layer? That is endoderm. This is endoderm. So pharyngeal pouch 1 forms the endodermal epithelium of middle ear cavity and eustachian tube. Where is eustachian tube communicating? To the nasopharynx. This is pharynx, nasopharynx. So nasopharynx connect with the middle ear cavity via eustachian tube. Their epithelium is endoderm, endoderm of pouch 1. Now if this is the middle ear cavity and that is the external ear cavity, what is this membrane between the two? This is tympanic membrane and it has all the 3 germ layers. If pouch 1 become middle ear cavity and cleft 1 become external ear canal, then what is the membrane between the two? External ear canal and middle ear cavity, the membrane between the two is tympanic membrane. Tympanic membrane has all the 3 germ layer. The outer epithelium of tympanic membrane is ectodermal of cleft 1. The inner epithelium of tympanic membrane is endoderm of pouch 1. And the connective tissue of tympanic membrane is? Connective tissue of tympanic membrane is neural crest cell derived secondary mesenchyme. The connective tissue of tympanic membrane is the neural crest cell derived secondary mesenchyme. Now what is pouch 2 giving? Pouch 2 will give us tonsillar epithelium. Pouch 2 will give us tonsillar epithelium. Tonsil epithelium is endodermal in origin. So tonsillar epithelium is endodermal in origin coming from pouch 2. And what about pouch 3? Pouch 3 we have learnt PP3 tip. PP3 tip. Now when you say PP3 tip, what is PP3? Pharyngeal pouch 3. And what is tip? You will see it will have a dorsal portion and a ventral portion. Ventrally is the thymus and dorsally is inferior parathyroid. So you can tell that third pouch will have dorsal ventral portion. On the dorsal side you will have inferior parathyroid and on the ventral side you will have the thymus. And PP3 tip is missing in DiGeorge syndrome. In DiGeorge syndrome PP3 is missing. Pharyngeal pouch 3 is missing. So thymus is missing. And because thymus is missing, there will be reduced cell mediated immunity, recurrent infections in the baby. So as the DiGeorge syndrome, as the DiGeorge syndrome, PP3 is missing, thymus is missing, T lymphocytes are missing, and T lymphocyte missing, then cell mediated immunity is down and bacterial infections. What about inferior parathyroid? Inferior parathyroid, a question comes, is missing hypocalcemia. And because of hypocalcemia, this Vostek sign will come positive. Vostek sign. Can you tell me the details of Vostek sign in the chat? Vostek sign in the chat, how do you do Vostok sign? And why do you do Vostok sign? Vostok CH is silent. This question has come 3 times in the last 3 years. Last 3 years, 3 times. Just in front of tragus, in a baby, tetanic muscular spasm, facial twitching, correct. Puneet Mangal, yes, correct. Hypocalcemia, yes, correct. So facial twitching, hypocalcemia, just in front of tragus, you are just tapping cheek muscles, will go into spasm due to hypocalcemia. Tetanic spasm. So that is a feature of DiGeorge syndrome. That is a feature of DiGeorge syndrome. So what happened here? I told you, neural crest cells migration problem. Neural crest cells do not come here, do not stimulate the pouch 3, and pouch 3 do not form thymus and inferior pethod. I'll repeat again. What is the problem in DiGeorge syndrome? Problem in DiGeorge syndrome is failure of migration of neural crest cell. And as the neural crest cell do not come here, do not stimulate the endoderm. If you do not stimulate the endoderm pouch 3 will not form the thymus inferior pethod. And then there can be Vostok sign positive. And these babies, mostly they die because of aorta pulmonary septum anomalies. They can die of bacterial infection also. Recurrent bacterial infection also. Very rarely they die of hypocalcemia. DiGeorge syndrome babies can die of bacterial infection, very rare. Can die of hypocalcemia, very rare. Mostly they die because of aorta pulmonary septum anomalies, because AP septum also come from neural crest cell. If neural crest cell is not migrating properly, then cardiac defects are the most common cause of death in DiGeorge syndrome. Now be careful, in DiGeorge syndrome they will give you option of pouch 3 and pouch 4, which is missing. You say both are missing. In DiGeorge syndrome, not only pharyngeal pouch 3 is missing, but pharyngeal pouch 4 is also missing. But if you have to choose between them, then pharyngeal pouch 3 is first answer and pharyngeal pouch 4 is next answer. But both of them are missing in DiGeorge syndrome. Now, what is pharyngeal pouch 4 doing? Pharyngeal pouch 4 will also have a dorsal component which will form superior parathyroid. And what will be ventral then? You will see that pharyngeal pouch 4 will have a dorsal ventral component. On the dorsal side, you will have superior parathyroid developing, which can again be missing in DiGeorge syndrome, because in DiGeorge syndrome, pouch 4 is missing. So superior parathyroid is missing. If superior parathyroid is missing, there will be less of parathormone. If there is less of parathormone, there will be hypocalcemia. Hypocalcemia is because of deficiency of parathormone, because parathyroid gland is missing. Now my question to you is, if pharyngeal pouch 4 dorsally you have superior parathyroid, what is ventrally present? What is present ventrally? Ventrally what we have is the ultimate branchial body. Ultimate branchial body, which is a remnant of pharyngeal pouch number 5. Which is a remnant of pouch 5, but pouch 5 disappears. So I'll repeat again. If pouch 4 dorsally you have superior parathyroid, which may be missing in DiGeorge syndrome, leading to deficiency of parathormone, leading to hypocalcemia, that is one discussion. Second is, what is ventral? Ventral is ultimate branchial body. And where is ultimate branchial body coming from? It is coming from pharyngeal pouch number 5, which is rudimentary, leaving behind this body. So pharyngeal pouch 5 is rudimentary. It leaves behind ultimate branchial body, attaches to fourth pouch. As it attaches to fourth pouch, it will receive what is called as neural crest cells, and those neural crest cells will then form parafollicular C cells of thyroid and giving the C hormone, which is calcitonin hormone. So the neural crest cells, those neural crest cells. I started my class with neural crest cells, and if you think that you know about neural crest cells, then you are hugely mistaken, because there might come a time that will talk about neural crest cell in full body, we don't know much about them yet. So it is those neural crest cells, they were migrating and populating the ultimate brachial body, and those neural crest cells change themselves now into parafollicular C cells of thyroid, giving C hormone in thyroid, which is calcitonin hormone. And that calcitonin hormone, C cell, C hormone, calcitonin hormone, is to antagonize parathormone, because there should be a balance of blood calcium. So C calcitonin is the hormone which is antagonizing the parathormone, so that there can be balance of calcium. They work upon bone, intestine and kidney. Work upon bone, intestine and kidney, because intestine you can absorb calcium, kidney you can excrete calcium, bone you can resorption of bone and bring calcium into blood. So you can increase blood concentration by parathormone and antagonize it by calcitonin. This is about the pharyngeal cleft and pouches. What about the arches? So in between here you will have the arches, that is the mesoderm. Mesoderm will form the arches. Now if you say this is arch number 1, this is arch number 2, arch number 3, arch number 4, actually there will be 6 arches, and they will be mesodermal, and they will be forming some bones like mandible bone, malleus incus bone. So mandible bone, malleus incus bone develop in first arch. Mandible bone, malleus incus develop in first arch. This will form mandible bone, malleus incus from neural crest cell, because this is neural crest cell derived mesenchyme. This is neural crest cell derived mesenchyme, so neural crest cell will form malleus incus and mandible bone. And second arch will form stapes and upper hyoid. Stapes and upper hyoid. So second arch will form stapes bone in the middle ear cavity and upper hyoid. What about lower hyoid? Lower hyoid come from third arch. Third arch, neural crest cells. Third arch, neural crest cells, they will give us hyoid bone. And what is fourth arch giving? No bone, no bone. There is no bone after that. Okay, so this is about the pharyngeal arches. Arches themselves are made up of mesenchyme, and mostly it is the neural crest cell derived mesenchyme. But then be careful, as I told you, most of the head neck mesoderm is from neural crest cell. What about the muscles developing in the arches? Like muscles of first arch, mastication, muscles of second arch, facial expression, muscles of third, fourth, sixth arch, palate, pharynx, larynx. Do they come from neural crest cells? Neural crest cells do not form skeletal muscles. Neural crest cells do not form skeletal muscles. If neural crest cells do not form skeletal muscle, then where are these muscles coming from? They are not from secondary mesenchyme. They are not from secondary mesenchyme. If they are not from secondary mesenchyme, then where are they from? They are from primary mesenchyme. They are from para-axial mesoderm, primary mesoderm. So you are telling the bones are from secondary mesoderm, like malleus incus, stapes and mandible and hyoid, secondary mesenchyme, neural crest cell. Yes, but not the muscles, because neural crest cells do not form skeletal muscle. If neural crest cells do not form skeletal muscle, then who is forming skeletal muscle? Somites, paraxial mesoderm. From back they will reach here. From back they will reach here. Para-axial mesoderm. Vertebral column. The vertebra develop from paraxial mesoderm. Vertebral column, the vertebra develop from para-axial mesoderm. And that paraxial mesoderm, not only from vertebra, it will form muscles also. And those muscles will migrate here. But there will be primary mesoderm. So which muscles develop in first arch? Which muscles develop in first arch? As you talk about the arches, you talk about their nerve also, and then you talk about their name also. So first arch, I have mandibular trigeminal and muscles of mastication. In the first arch, I have third division of fifth nerve, mandibular branch of trigeminal, and muscles of mastication. And what about the second arch? Second arch, I have the facial nerve for muscles of facial expression. Muscles of facial expression. So second arch, facial nerve, muscles of facial expression. What about the arch number 3, 4, 6? If you say arch number 3, 4, 6, then I have muscles of palate, pharynx, and larynx, which are muscles of speech and swallowing. So muscles of speech and swallowing, arch number 3, 4, 6, muscles of palate, pharynx, larynx, muscles of speech and swallowing. And which nerves? For third arch, I have ninth nerve. For fourth and sixth arch, I have 10 and 11th nerve. Now number 9, 10, 11. So arch number 3, I have glossopharyngeal nerve, and arch number 4, 6, I have the vagus and accessory nerve, vagus accessory complex, vagus accessory complex. And what are they doing? They are basically controlling the muscles of palate, pharynx, and larynx. Cranial part of 11th, this is cranial part of 11th. Now be careful. Recently, the Gray's Anatomy is telling cranial part of accessory nerve does not exist, and maybe it doesn't exist. So cranial part of accessory nerve does not exist, and maybe it doesn't exist, but it does exist in BD Choracea. And until the time it is existing in BD Choracea or Vishram Singh, we cannot say that it doesn't exist. So it does exist. And in fact, most of the muscles of palate, pharynx, larynx are supplied by cranial accessory nerve, by vagus accessory complex. I'll repeat. Gray's Anatomy is telling cranial accessory nerve do not exist. So should we follow Gray's Anatomy blindly? No. You cannot follow it blindly until it disappears from BD Choracea or Vishram Singh. It is still there. And what is written in BD Choracea and Vishram Singh still? That there is a vagus accessory complex, vagus accessory complex. In that also, it is cranial accessory nerve which supply most of the muscles of palate, pharynx, and larynx. So muscles of palate, pharynx, larynx are supplied by cranial accessory nerve. There is a nucleus. It is called nucleus ambiguous. Nucleus ambiguous. So there is a nucleus ambiguous which is controlling these muscles of palate, pharynx, larynx, and nucleus ambiguous is contributed by nerve number 9, 10, 11. It is contributed by nerve number 9, 10, 11. But chiefly it is 11th cranial which is important. Now, a question has come. It was asking, there is a jugular foramen fracture. Jugular foramen fracture. And nerve number 9, 10, 11 are compromised. So, what will be the problems? If there is a jugular foramen fracture through which nerve number 9, 10, 11 are passing, what will be the problem? Problem will be difficulty speech and swallowing. There will be difficulty speech and swallowing. That will be the problem. Now, ninth nerve itself becomes quite important. Ninth nerve itself becomes quite important, and that is why we are focusing on details of ninth nerve now. Because recently I have seen that there are some questions which have appeared on ninth nerve, like this one. You are doing a gag reflex, taking a stimulator, gag reflex, and you are trying to touch posterior 1/3 of tongue or tonsillar area or the soft palate. Ninth nerve stimulation, oropharyngeal isthmus. Oropharyngeal isthmus, either you are touching the posterior 1/3 of tongue or the palate, this tonsillar area, or the soft palate. You are activating ninth nerve. What will happen? If you activate the ninth nerve, there will be a gag reflex, which is also called palatal reflex, and there will be a sudden spasm of muscles of palate, pharynx, and larynx. Muscles of palate, pharynx, and larynx. There will be sudden spasm. So what is the pathway? Pathway is You have activated ninth nerve. It will activate nucleus tractus solitarius. Gag reflex. As you activate the ninth nerve will activate nucleus tractus solitarius, which is a sensory nucleus, because these are sensations. So that sensory nucleus will activate a motor nucleus, which is nucleus ambiguus. And as the nucleus ambiguus is activated, you will see now number 9, 10, 11 activated. Muscles of palate, pharynx and larynx will be activated. Sudden swallowing movement will be happening, gag reflex. So what will happen if ninth nerve is lesion in jugular foramen, which is called Wernicke syndrome. Wernicke syndrome. Wernicke syndrome, in the last 3 years, many questions have come. So Wernicke syndrome is something wrong with jugular foramen, maybe jugular foramen fracture, and it has damaged number 9, 10, 11, ninth nerve. And you are doing this reflex. As you do this reflex, it will not be working. Why it will not be working? Because in Wernicke syndrome or jugular foramen syndrome, number 9, 10, 11, if it is compromised, then palatal reflex will be gone. Ninth nerve cannot carry information towards nucleus tractus solitarius, and it cannot give it to nucleus ambiguus, and muscles of palate, pharynx, larynx will not be going into spasm or swallowing, reflex will be lost. Now in Wernicke syndrome, how do you check the 10th nerve? How do you check the 10th nerve? To check the 10th nerve, it's very simple. You just ask the patient to open his mouth. And you can take a tongue depressor also and ask him to say, ah. Ask him to say, ah. What will that happen? That lead to saying, ah. Palatal muscles should contract. And who is supplying palatal muscles? The muscles of palate, pharynx and larynx are supplied by the nerve number 9, 10, 11, specifically cranial 11. But then cranial 11 requires 10th nerve to carry the fibers. The fibers of 11th nerve go with 10th nerve. That is why it is called vagus accessory complex. Point is, let us assume there is a lesion of the left-sided 10th nerve. It is not working. Let us say left-sided 10th nerve is not working. There is a left vagus lesion. If there is a left vagus lesion, the left palate will not be going into contraction. Whenever there is a contraction, there should be elevation. Whenever there is a contraction of palate muscle, there should be some elevation. But it won't be elevating. And what about the right side? Right side is normal, so it will be elevating. So there will be one elevation, but on the other side, instead of elevation, in fact, there will be a sagging down. Because muscles are flaccid, they will sag down. So I have a patient who has left-sided 10th nerve injury. I told him to say ah, and I expected that the palatal muscles should contract and palate should be elevated. It is elevated, of course, on normal side, right side. It was elevated. But on the left side, it was not elevated. In fact, it was sagging down. And because of that movement, see what is happening to uvula. The uvula, you can see, has deviated towards the normal side. So normally uvula is in the midline, soft palate, midline. It will deviate. And why it will deviate to normal side? This is lesion side. Because sagging here and elevation here, that is why. So uvula deviate to normal side, right side is normal, left sided 10th nerve lesion. This is how you check the 10th nerve. And about the 9th nerve, as I was telling, 9th nerve has several. This is looking from side view. You are talking about the parotid gland here. Parotid gland. It requires 9th nerve pathway. So what is this 9th nerve? What are the various functions of 9th nerve? First of all, 9th nerve will send a tympanic branch into middle ear cavity and supply not only middle ear cavity by tympanic plexus, It will also supply eustachian tube and mastoid air cells. So ninth nerve, glossopharyngeal nerve, will give a tympanic branch to give tympanic plexus, which will supply not only tympanic cavity, middle ear cavity, but also mastoid air cell and eustachian tube. Plus it also carries secretomotor fibers towards parotid salivary gland. So tympanic branch, which later will be renamed as lesser petrosal nerve, is carrying preganglionic fibers towards the parotid gland. When you say ninth nerve, tympanic branch, which later is renamed as lesser petrosal nerve, is carrying preganglionic fiber, it is carrying it to which ganglion? To the aortic ganglion, and from the aortic ganglion the postganglionic fibers will be carried by the auriculotemporal nerve, which is branch of mandibular trigeminal. I'll repeat again. Which nerve carry the preganglionic fiber to aortic ganglion? It is two of them, branches of 9. Number 1, tympanic branch, renamed as its continuation as lesser petrosal nerve, and who carry postganglionic, that is auriculotemporal nerve, branch of trigeminal, carrying postganglionic fiber to parotid gland. And when you remove parotid gland sometime, you will definitely damage auriculotemporal nerve, and there can be a syndrome which is called as Frey syndrome. So what is the feature of Frey syndrome? You have removed the parotid, and when you remove the parotid, definitely you will damage the auriculotemporal nerve because it is inside the gland, and as you damage it, there will be a Frey syndrome or auriculotemporal syndrome. Actually, this nerve is supposed to innervate parotid gland, but you have removed the parotid gland, so instead of parotid, it will regenerate and innervate some sweat gland and skin and sweat gland. And because now auriculotemporal nerve is innervating sweat gland and skin, whenever this patient is having exposure to food instead of saliva, what happens is there will be hotness, redness, and sweat will come. Hot, red skin and sweat will come. That is called as gustatory sweating or Frey syndrome or auriculotemporal nerve syndrome. Auriculotemporal nerve syndrome, Grace syndrome, gustatory sweating, all these, because you damage the auriculotemporal nerve. It is difficult to escape the injury of this nerve. Though if you are a good surgeon, you may. Okay, what is the other function of this nerve? Other function of this nerve is, as you can see, it was supplying a muscle of pharynx called stylopharyngeus muscle, developing in third pharyngeal arch. It is a pharyngeal elevator. So glossopharyngeal nerve supply stylopharyngeus muscle coming from styloid process to pharynx, elevating the pharynx. It is a pharyngeal elevator for swallowing. Ninth nerve supplying stylopharyngeus coming from styloid process to pharynx and elevator of pharynx for swallowing movement, developing in third arch. It's a nerve of third arch. So nerve of third arch, muscle of third arch. What else it is supplying? It is supplying, as we discussed, posterior 1/3 of tongue, posterior 1/3 of tongue, and then it is supplying tonsillar area. It is supplying the soft palate also. Oropharyngeal isthmus, where you were doing the gag reflex, the palatal reflex, ninth nerve. So ninth nerve supplies posterior 1/3 of tongue because that develop in third arch. Posterior 1/3 of tongue develop in third arch, hence the nerve is glossopharyngeal nerve of third arch. It is also supplying the region of the tonsil. It is supplying the region of the soft palate. There was a tonsillitis. Why ear pain? There was a case of tonsillitis. Why ear pain? Referred otalgia. Brain gets confused sometime. The brain gets confused and brain is thinking the pain is not coming from tonsil, the pain is coming from middle ear cavity because of the same nerve supply. So referred otalgia. Any tumor in the posterior 1/3 of tongue, any tumor in the posterior 1/3 of tongue, any tonsil pathology or any soft palate pathology can present as earache, because this area sensation is by ninth nerve and middle ear cavity is also ninth nerve, especially tympanic branch of glossopharyngeal nerve. That nerve is responsible for referred pain. Referred means pathology is here, pain is there, pain has been referred, and this is a confusion which brain sometimes feels. And of course ninth nerve is important for carrying sensation from the carotid body, carotid sinus, carotid body for chemoreception and carotid sinus for pressoreception. Blood pressure sensation towards brain, carotid sinus, and blood pH, blood CO2, blood pH, blood CO2, especially towards brain. Blood pH, blood CO2, chemoreception, carotid body. That sensation is also carried by ninth nerve, sinus nerve, ninth nerve. So my point is, on ninth nerve in last 5 years, ninth nerve last 5 years, there are some 15 to 20 questions, 15 to 20 questions. Like one of that was, in jugular foramen, this is ninth nerve, this is 10 and 11. The ninth nerve has a separate dural sheath. 10-11 has a combined dural sheath. So when we talk about jugular foramen, now number 9 to 11 are passing. In jugular foramen, ninth nerve is more anterior compared with 10 and 11. Ninth nerve will have a separate dural sheath, and 10 and 11 will have, that is vagus accessory complex, vagus accessory complex, supplying muscles of palate, pharynx, larynx. Though here 11th, not only cranial will be there, spinal will be there as well. It has come here. So in the jugular foramen, now number 9 is more anterior and has a single dural sheath, is a question. And 10, 11 will have a common dural sheath. And here 11th nerve is not only cranial, it is spinal also. So what will happen in Wernicke syndrome? What will happen in Wernicke syndrome? Tell me the clinical features. In Wernicke syndrome, the clinical features are, number 9 is compromised. So sensation of middle ear cavity is gone and parotid secretion is gone, and sensation of oropharynx is gone. One muscle is paralyzed. Okay, that is 9th nerve. What about 10th nerve? 10th nerve, 11th nerve together, they work for muscles of palate, pharynx, larynx. Difficulty speech swallowing. Difficulty speech swallowing. You will find whichever side the Wernicke syndrome is, that vocal cord is in abducted position, basically. So you are telling that means it is not midline. It is not midline. So as in Wernicke syndrome, 10th nerve is compromised, there will be problem with vocal cords. Yes, 10th nerve lesion can be identified by looking at the vocal cords. Whichever side you have Wernicke syndrome, that vocal cord will not align in the midline. It will be slightly away from midline. And what about 11th nerve? 11th nerve, difficulty speech swallowing, hoarseness. Aspiration syndrome. Patient is sleeping, aspirating into lungs. Aspiration syndrome, because this area which detects, which reflects, which gives you cough reflex, that cough reflex will be dampened. Cough reflex is dampened because this area, wherever the secretions go, oropharynx, that area is under 9th, 10th nerve. So aspiration syndrome. And 11th nerve, spinal, if it is compromised, then a spinal accessory nerve is compromised, then a spinal accessory compromised, then drooping of shoulder and difficulty turning the neck to opposite side. Sternomastoid paralyzed, trapezius paralyzed. So in Wernicke syndrome, 11th nerve, spinal accessory nerve compromised. Compromised trapezius, there is a drooping of shoulder, difficulty shrugging the shoulder. Plus sternomastoid is compromised, difficulty turning the neck to opposite side. These are all features of Wernicke syndrome. I have told you these things in the last 5 years, some 15 questions, and it goes on, never ends. ब्रेक तो अब हम ले ही लेंगे, कल आएंगे अब हम. So कितने बजे हैं? What is the time? 7, 4, 3, 7. Okay, 3 hours. We have spent some 3 hours, and I hope we have covered some significant portions. पिछली बार, last time, I saw in the chat, some students were asking, how many questions will come from this class, whichever session they are taking. Will all the questions come from this class in the next INI-CET? In the next INI-CET exam, 3 hours today, 3 hours tomorrow, 6 hours. So there are some students who will be asking, in 6 hours, whatever sir has taught us, how many questions will come in INI-CET? All the questions will come from here only. My dear students, if I was so capable, first of all, if I had made the question paper, then of course. But I did not make the question paper. Second thing, if I was so capable that in a single shot I can revise all the anatomy within 6 hours, all the questions will come from here only, then what is wrong with me that I am teaching anatomy for 100 hours? Why should I waste my time or your time teaching anatomy for 100 hours and still worrying that sometime question may come beyond that? If it was possible to teach you everything in 6 hours only, why should I be using 100 hours and still worrying that maybe something is left? So 100 hours, the main content, 20 hours is the rapid revision, 6 hours is the ultra rapid revision, and still I am worried that question might come from beyond this. So please don't, though maybe it is a blessing or maybe it is our hard work. See, blessing, luck is nothing but your hard work. Maybe it is your hard work, your genius or your whatever, that whatever we teach, questions definitely appear from there. There are a lot of logistics here. I can explain how it works, but it works. And sometimes it is so surprising that when exam is over and students are giving us questions and we are smiling, sometime I have felt, not sometime, many times I have felt, was the examiner sitting in my class and then prepared the question paper thinking that I should ask questions from only whatever he has taught? So that is a funny feeling, but it has happened very often. It has happened many times, and it's a funny feeling, but it is true. So the point is, maybe it is our hard work, maybe the system is like that, but we are on track. So whatever we teach, examiner is asking, and we don't have any direct correlation that examiner knows me or I know the examiner, nothing like that. But we know that there is a system, and in the system it is an ecosystem basically. And it works. So have faith. Whatever I teach, maybe not many questions will come from here only. So I take leave today, and we'll meet again tomorrow, 4 p.m., 4 to 7. We'll try to finish off the lower portion of the body, that is thorax, upper limb, abdo, pelvis, lower limb. Take care. All the best.